Thank you. Good evening. Welcome, delegates. It is my proud privilege to welcome all delegates from over 30 countries, 630 delegates, and many more are joining live on our social media, including LinkedIn, YouTube, Facebook, and others, many more. I welcome all on for this global conclave on head and neck cancers. Program chairs for the entire concept are Dr. Anil De Cruz. Dr. De Cruz is President UICC. Sir is President Indian Society of Thyroid Surgeons and currently is Director Oncology, Apollo Hospitals, Mumbai. He has many accolades to his hats. So many novel things Sir has done. Globally, it is a long list of publications and so many things. And another program, our next other program chair is Dr. Sanjeev Mishra. Sir is President ISO and currently Director AIMS Jodhpur. He has been in several other leading positions in oncology. With this, I hand over and welcome Dr. De Cruz.
Good evening, Rajesh. Thank you for your kind words. It's a privilege to be here today on a very important day for us in cancer, the 4th of February, which is World Cancer Day. For years, nothing was being done on World Cancer Day, and I'm delighted to see an increase in the number of activities across our country and globally as well. Before I start, I want to thank the organizers, Biocon Biologics, for a very, very important initiative, and the Manage Health Foundation, of which Rajesh is part of, which has really taken the initiative to organize this meeting in conjunction with the Indian Society of Oncology, the IASO, which is the Indian Association of Surgical Oncology, and the ISMPO, of which Dr. Govind Babu is the president. So thank you very much to the organizers for organizing this important thing. I know it's World Cancer Day, and we are having a conclave on head and neck cancers, but I think it's fitting because head and neck is really the Indian cancer. Nearly 1/3 of all our cancers are head and neck. Whatever you train with, including if you do your general surgical oncology, 40% of the workload of most general surgical oncologists is head and neck. And to have this event on such an auspicious day on head and neck, I think is very apt. As I said, I wear two hats. And for me, this is a very, very important day, both as World Cancer Day, because I'm president of the UICC. And for those of you all who are not aware, or many of you all may be aware, it was established on the 4th of February 2000. That's the World Cancer Day at the World Cancer Summit against a program that was organized called Against Cancer for the New Millennium. So at the turn of millennium in Paris, a decision was taken led by the UIC to commemorate the 4th of February as World Cancer Day. The primary goal of this day is to significantly reduce illness and death caused by cancer. And each year, all members of the UICC and now even others celebrate this day. But just to give you an idea, there are about 1,000 activities that are taking place from UICC members who report back to the Geneva office. There are so many other programs that happen that may not be recorded. So a conservative estimate of official programs is about 1,000 activities across 100 different countries. And it's one of the most popular trending topics on Twitter. A couple of years back at the board meeting, they would always present the statistics of World Cancer Day. And we had at one time across various hits, searches, activities amongst all people who did nearly 6 billion. And I would say 6 billion is the world population. So just to give you an idea on the number of people who are very keen on this. Generally, what happens is a lot of cities, a lot of governments have started supporting this activity, and they light up very important landmarks in orange and blue. In 2019, that's about 3 years back, 55 landmarks in 37 cities participated in this lighting of the landmark initiative. And at least 60 governments officially observe the World Cancer Day. Now, the World Cancer Day used to have a theme initially, but about 3 years back, we decided at the UICC to have a theme every 3 years. So the last 3 years, the theme was, I can and I will. And this time, starting for the first year now, we have a new theme. And this is again on a three-year tenure that we'll have this, and that is closing or close the care gap. And basically, whenever you look at outcomes of cancer, there is an inequity in cancer care that costs lives. People who seek cancer care have a number of barriers that they experience. For example, there could be discrimination based on your education level. It could be geosocial, that's your location. It could be discrimination based on your ethnicity. Gender in our country is just so common. Sometimes the female gender does not get the required care that they need to get. It could be sexual orientation, age. As I tweeted a couple of days back, 65% of cancers occur in people over the age of 65. And very often, if you have an elderly person coming 60, 65, longevity now is 80. People would say he's old, let's keep the resource for someone younger. Various other forms of discrimination are disability, lifestyles. And these are just a few factors that I've tried to highlight to tell you that there is inequity in cancer care. And all our efforts should be to close the care gap. I tweeted this morning that today is World Cancer Day, and I kind of wished people on World Cancer Day. And I said, we must be aware that finally, half the cancers are preventable and the majority are curable if detected early. And I think if we can only go ahead with these two important points, awareness and early detection, I'm sure we will be able to close the care gap. And I think that's important. And what could be more important than on head and neck, where we know the major etiological factors, and as we go through the day, I'm sure we'll have a number of speakers who will be highlighting it. And I'll also be leading a panel discussion in about half an hour's time, where we'll discuss how we can decrease the incidence of head and neck cancer. So I'm not going to take more time. I once again congratulate the organizers for choosing an important topic on a very important day. And I'm delighted to be part of this program and look forward to some great interactions as the event progresses. Thank you, Rajesh, and back once again to the studio and you.
Thank you very much, sir, for enlightening all of us about the entire concept and theme of World Cancer Day. It is very, very important, close the care gap, the theme which UICC has adopted. And with this, I will introduce the next speaker. Our next first speaker for the day is Dr. Pankaj Chaturvedi. Dr. Chaturvedi is Deputy Director, Center for Cancer Epidemiology, Tata Memorial Center. He is Professor and Surgeon, Department of Head and Neck Surgery, Tata Memorial Center, and he has been having multiple hats always. He is very vocal for his anti-tobacco campaign and tobacco-related campaigns taking up with the government of India and various bodies. And in this leadership, he has won many fights also and modified the laws also with his influence and advocacy. He is also Secretary General for International Federation of Head and Neck Oncologic Societies. He will be speaking on oral cancer awareness, prevention, early detection, and treatment. Over to you, Dr. Pankaj.
In next 20 minutes, I'll be talking about a very common cancer, how we can win the war on this cancer by awareness, prevention, early detection, and proper treatment. The problem of India is manifold. And for any problem, first, we have to understand the magnitude of the problem. In India, we have 3 million people living with cancer. The incidence is around 1 million. As per the Globocan WHO data, nearly half of the newly diagnosed cancer patients, they die within 12 months of diagnosis. That means we are losing 5 lakh people every year. Since India is a country of young people, when people die at a very young age, there is a loss of productivity. And loss of productivity, when we calculate because of cancer in India, around 6.7 billion in 2012, it is almost a huge number in 2012 itself, and it must have increased dramatically in last 8 years. Now, the grim reality is that the doctors in India are reached or approached when the patient has a very advanced cancer and the recovery is not possible. As I said, that majority of our patients are in the productive age between age 30 to 69. And when they die, it's a loss of labor and loss of productivity to the nation. And also I said that 70% of the people that die within the first year of diagnosis because of late detection. And what is more important to understand and quite revealing, that nearly half of our cancers are lifestyle related. And more important is that, again, because we are predominantly young population, 15% of the cancers in India are related to a minor age group. India is a very unique situation where there is a dramatic reduction in the communicable disease because of the success of the medical treatment. However, at the same time, we have increased in the number of non-communicable diseases because of lifestyle changes, urbanization, and more important, people are living longer. And therefore, a country like India has a huge burden of smallpox, filaria, malaria. Those were the killer days. And those have been conquered. But now we are still dealing with infectious diseases such as tuberculosis and malaria. And sometimes there are epidemics of leptospirosis and all that. So we are having the double burden of communicable diseases as well as non-communicable diseases, which is straining our infrastructure. And looking at the cancer, this is an old data where you can see that the cancers of the lung, oral cavity, breast are increasing. And fortunately, cervical cancer, which used to be the #1 cancer in the women, is decreasing. Now, this is for the lay people. This is to understand that cancer is not actually as bad as people believe. If you look at the hypertension, it's a lifelong treatment. Diabetes, again, lifelong treatment. Tuberculosis, 9 months of treatment. Hepatitis, hyperlipidemia also again requires a long treatment. Look at mouth cancer and cervical cancer. If they are detected early, there is a caveat. If they are detected early, they can be treated within 7 days. And if they are detected advanced stage, then certainly we need to give chemotherapy, radiotherapy as well. But again, unless it is stage 3, stage 4, we will be able to cure a reasonable number of them. Now, how do we create awareness among people? How do we create atmosphere in the society where more and more people can come for early detection? So this is what we started. It's an online platform where people can, doctors can educate themselves, lay people can educate themselves. This has been adopted by the Union Ministry of Health, and at the end of the whole lecture and self-assessed questionnaire, we are able to generate certificates for them. This entire program has been in several states accredited by the medical councils, state medical councils. We also have been utilizing, which has become very relevant in the COVID time, is an ability to take the second opinion online. So this is the Navya platform. The patient submits and deposits their report onto that platform, and then back-end people collate it into a very simple, readable format for the doctors, who are able to make a decision within 2 to 3 minutes and give their second opinion. So this is very, very useful for people living in far-off area for which they have to travel otherwise to Mumbai. So with this tool, they are not able to really required to come all the way to Tata Hospital, Mumbai for second opinion. We have also been utilizing SMS, which is a very simple tool to keep people reminding about the harmful effects of tobacco use and many other habit disorders. At the same time, reminding them for self-examination, empowering them to take care of their health. So this study showed that it really works when people get repeated reminders about health awareness. There are people in the parts of India who are not able to even visit the nearest cancer hospital because of the prevalent myths, or because of the financial problem, because of the cultural issues. So there we have utilized the services of Lifeline Express to reach out to these remote areas and not only offer surgery, but also create awareness amongst the population. Now, this is something that is that we have to understand, that if we look at the entire spectrum of cancer in India, starting from the central nervous system, which is very, very, which is less common. The other extreme is mouth cancer, throat cancer, lung cancer, which are typically tobacco related. It forms the big burden of the disease. Now, in Tata Hospital, we register around 60,000 new cancer patients, of which around 25% or 10,000 or 15,000 are tobacco-related cancers or head and neck squamous cell carcinoma. And if you look at the distinction between the male and female cancer, in the males, we have the buccal mucosa and tongue cancer, which is the commonest cancer. And most of these patients, they present in very advanced stage. And that is a challenge that we have to deal with. And this advanced stage, happens because of the poverty. That means they are not able to go to the doctors. There are lack of good infrastructure in the public domain, in the villages and in the taluka level. And of course, there is a lack of literacy and awareness among the people. Now, in India, if we talk about oral cancer, then we are talking about 1 lakh new cancers every year. And of them, nearly half die within 12 months of diagnosis. Now, oral squamous cell carcinoma, basically, it's a very, very obvious disease which can be seen by clinical examination. Here you see that if you do clinical examination, if you find these suspicious ulcer or growth, this is very, very classical of mouth cancer. And if you look at how from a normal mucosa till it becomes cancer, it takes 10 to 15 years. This only means that once a person starts tobacco, it takes 15 years for him to develop cancer. And therefore, we have this entire opportunity of 15 years to reverse the process of cancer in the population. Now, If you just look at these images, on the right hand side, you have submucous fibrosis. This is purely because of areca nut and supari or betel nut. And these patients, nearly 10% of them, they may convert into malignancy. This is a field cancerization and a leukoplakia. Nearly 30% of this may have a conversion into malignancy. So if we see these images in any individual, they need some treatment, they need surveillance, because the chances of malignant transformation or cancer development is very high in them. Unfortunately, in Mumbai Cancer Registry and even in Gujarat Cancer Registry, if you see, there is a dramatic increase in the number of cancers in the younger age. And that is where it is very important that we have to put our focus on prevention of oral cancer. Is there any tool by which we can facilitate early diagnosis? So there are a lot of adjuncts currently available in the market, but none of these adjuncts are really helpful. Similarly, there are a lot of drugs which are being sold or promoted, like curcumin, NSAID, spirulina, whether they are beneficial or not. And most people believe that it is still in the research domain, and it is not possible for us to really prescribe them and hope that the malignant transformation can be stopped. Then how do we tackle the burden of oral cancer? And the oral cancer means that cancer which is a lead killer in the men. So cure, certainly it is something which still we are working on by chemotherapy, radiotherapy and surgery. But look at prevention. Now, why we say that prevention is a very, very good tool for oral cancer? Because 90% of the cancers, they do have some etiology. Look at tobacco, alcohol, oral hygiene, human papillomavirus, areca nut, and up to Fanconi. These are the risk factors which are associated with oral cancer. And you can imagine, if we are able to deal with each of the risk factors, we will certainly reduce the burden of oral cancer. Now, oral hygiene is something which is very simple. And if we can promote oral hygiene in the society, that itself will reduce the burden of oral cancer very significantly. Now here, if you see, this is our national animal, this is our national bird, this is our national flower, and this is our national mouth. And these people, they keep spitting all the time, who are tobacco users. And unless we reduce the burden of problem through preventive and behavioral changes, such as people not using tobacco and causing public nuisance by spitting, or people at least not abusing their mouth with these harmful things, and go to the doctor whenever such a situation arises, or poor oral hygiene. Perhaps that is how we can reduce the entire burden of poor manifestations of early cancers such as dental caries, periodontal disease, malocclusion, and all that. And this can be done by all the civil society coming together and trying to reduce the level of poor oral hygiene. And in India, we have around 1.5 lakh, 9 lakh dental and 9.929 lakh medical practitioners. If all of us join, then certainly we can do a good service in a population of 1.3 billion people, where 27 crore are using tobacco. And this can be easily done as part of the National Oral Health Plan of Ministry of Health. Now, moving to tobacco, everybody knows tobacco is harmful. Every packet has a warning that it is harmful. And this was a entire chart that was put together by WHO as the preventive measures for non-communicable diseases. Non-communicable disease means cancer, cardiovascular illness, heart attack, cardiopulmonary disease, chronic obstructive pulmonary disease, and then more important is diabetes. So they looked at what are the preventive measures for these non-communicable disease, and the number 1 was tobacco use, number 2 was reduction in the dietary salt, 3 was obesity, 4 is harmful use of alcohol, and certainly there are other exercise and reducing the fat is also some of the things by which we can reduce the cardiovascular risk. Now, about tobacco, the government has done enough. Now, these are the movies that you see in the cinema hall. This is the warning that is there on the cigarette packet. Both are given and supported by Tata Hospital. And we have been trying to get this tobacco-led education in the textbooks, and we have succeeded in certain states. And there is a ban on sale of tobacco to the minors and near the educational institution. And I would urge every doctor, whenever you see a patient who is using tobacco, the patient may have come to you for any other disease, but if you find a history of tobacco use, please counsel them. It's a very, very powerful tool, and it is said that 2 minutes of advice by the physician can help a person quit tobacco as good as giving nicotine replacement therapy or any other treatment. There is a law for control of tobacco. It is called Cigarette and Other Tobacco Products Act, and this is under the Constitution of India. And all of you should be aware that sale of tobacco to minors is prohibited. Similarly, point of sale advertisement is not permitted. Any tobacco product cannot be sold loose. Similarly, every product should have a bonding. So these are certain provisions within the COTPA. And under this provision, and also Food Safety Act, the gutka is prohibited. Gutka is a combination of tobacco and areca nut in one sachet. It causes a huge burden of oral cancer, and this is banned. Not only gutka, in certain states, pan masala is also banned. Let us move to areca nut. Now, areca nut is something that most people believe that it is safe, areca nut or betel nut, but actually it is a carcinogenic substance. It leads to oral submucous fibrosis. And unfortunately, on television, many celebrities, they continue to promote it. And that is very sad, because areca nut not only causes cancer, but it increases the all-cause mortality in any population. Now, moving to alcohol. Alcohol is a group 1 carcinogen. Group 1 carcinogens that, based on the animal data, human data, epidemiological data, the WHO has confirmed that it causes cancer of the various parts of the body. Now, the question always comes up that, is there a safe level of alcohol? Now, there is a safe level of alcohol if you want to reduce the risk, but there is no safe level of alcohol when you want to eliminate the risk. The choice is yours, whether you want to eliminate risk of cancer or you want to reduce the risk of cancer. And certainly the guidelines always say that there is actually no safe level for elimination of the risk in a healthy human being. Now, this is the CDC guideline, which very clearly says that according to the dietary guideline for Americans, a moderate alcohol consumption is defined as having up to 1 drink per day for women and 2 drinks per day for men. However, the dietary guidelines do not recommend that individuals who do not drink alcohol should start drinking for any reason. Now, we next move to human papillomavirus. A lot of people think of human papillomavirus as a cause of cancer, which is true for cervix cancer, and it is strongly associated. It is now coming up for oral and oral pharyngeal cancers. But today, because most oral cancer patients, they're also tobacco users, so HPV, whether it is causally linked, becomes null and void, because the treatment remains same for those patients. However, there is a lot of studies coming in the West, and perhaps maybe another couple of years, based on those evidence, perhaps we'll be able to treat HPV cancers separately than we do currently. However, it is established that human papillomavirus certainly can lead to cancer. What I was talking about, whether the cancer caused by HPV are treated differently or not. So in the beginning, I told you that how oral cancer is the #1 cancer in Indian men and how it is killing our people. So how do we win the war on oral cancer? 3 aspects: primary prevention, secondary prevention, and screening. Primary prevention means that there should be a way that cancer does not happen. Secondary prevention means that if pre-cancer is already there, how malignant transformation can be stopped. And screening means that those people who have got cancer, how they can be detected in an early stage where their lives can be saved. So For primary prevention, alcohol, tobacco, and areca nut control is an evidence-based approach. Secondary prevention, tobacco cessation or areca nut cessation and alcohol cessation in those who are using it. And screening can be done only and best by visual examination based on the evidence that we have from India. So you can imagine that oral cancer is the lead cancer which is causing Indian men, and look at the what are the tools to conquer this cancer: alcohol, tobacco control, cessation, and visual inspection. None of them are rocket science. And if we all put our hands together for all these three preventive measures, we can wipe out oral cancer from India. Thank you so much again for this invitation, and I hope the session was very informative and useful for everyone. Thank you so much.
Thank you very much, Dr. Chaturvedi, for such a detailed elaboration on different aspects. And tobacco-related cancers. Tobacco has impact on multiple cancers, including the major one is head and neck. And what I feel in last year also I have proposed in one of the meetings that only enlarging this warnings and awareness may not work much longer, and our next 4-5 generations will go from this earth. Probably we have to work in the direction where in cultivation of tobacco, if stopped, and this is not just a dream. Our neighboring small country like Sri Lanka has done it. In 2017, they have banned the tobacco sales in their 100+ cities, and starting 2020, they have banned the tobacco cultivation also. So if Sri Lanka can do, many other countries also can do. So this is my proposal to August gathering in your own areas, if we can mobilize this. Thank you, Dr. Chaturvedi, once again. Now, I would like to welcome Dr. Nishant Agrawal. Dr. Agrawal will be speaking on HPV in head and neck cancer. Dr. Agrawal is Professor of Surgery, Chief Section of Otolaryngology, Laryngology, Head and Neck Cancer Surgery, Co-Director, Head and Neck Surgical Oncology from University of Chicago Medicine, and Professor of Surgery, Comprehensive Cancer Center, Radiation Oncology, University of Chicago. Over to you, Dr. Agrawal.
Thank you very much. It's a great honor to present on World Cancer Day, and I appreciate the invitation from Dr. De Cruz, and it's a great honor to speak right after Dr. Chaturvedi. So Dr. Chaturvedi introduced HPV and head and neck cancer, and I'll expand on the causative role of HPV in head and neck squamous cell carcinoma. So I am talking on behalf of ASCO. So ASCO also celebrates World Cancer Day. And the mission, as we've already sort of introduced, is conquering cancer through research, education, and promotion of the highest quality, equitable patient care. And you can see, again, this equitable patient care comes into play of even ASCO's mission. And the vision is really a world where cancer is prevented or cured, and every survivor is healthy. And the major initiatives of ASCO include journals, meetings, internet resources. There's a Research Cancer Foundation, and then a big data platform for cancer. So there's about 45,000 members of ASCO across 150 countries, and nearly 1/3 of ASCO members practice outside the United States. And there's discounted membership available for physicians practice in countries defined by the World Bank as low or middle income. So it's really an amazing organization, and invite you all to consider joining its membership. This topic has already been introduced. So there are about 600,000 cases of head and neck squamous cell carcinoma in the world. It's the sixth most common cancer. About 300,000 of the cases are actually in India. So the major burden of head and neck cancer of the world comes from India. Unfortunately, most patients present at advanced stage when the cancer is already metastasized to lymph nodes, and the prognosis is much worse when the cancer has metastasized to lymph nodes. The treatment is a combination of surgery, radiation, and or chemotherapy, and the 5-year survival is about 50%. In India, about 5 people in India die every hour because of oral cancer. Again, I told you the significant burden of head and neck cancer in India. Oral cancer accounts for approximately 30% of all cancers in India, and it's twice as common in men than women. We've discussed the risk factors already, but again, I think this is an important point that this is an essentially preventable cancer. So some of the lifestyle and environmental risk factors are smoking tobacco, alcohol, and betel areca nut. I will focus my talk on HPV, which is human papillomavirus. And there are other things, but you can see the top half of the slide is purely preventable causes of head and neck cancer. Hereditary germline mutations are fairly rare. There are disease processes like Fanconi's anemia, which is a very rare recessive gene that's inherited. And then bad luck, that just basically every cell replicates and there's mistakes that happen during normal cellular division. So this can happen to patients who don't do any of this, but it's fairly unlikely. So I'm going to switch the focus to the oropharynx because that's really the epicenter for HPV. So the oropharynx includes the tonsils, the soft palate, and the base of the tongue. And this is the epiglottis, which is the top part of our voice box. So this is really the epicenter of HPV-related head and neck cancers. And here's some pictures of a tonsil cancer here, and then a base of tongue cancer here. So you can see the tonsil cancers should be able to be detected by visualization. The base of tongue, unfortunately, is not really accessible beyond just feeling or palpation. So these cancers sometimes are diagnosed much later. And I showed you 2 pictures of Jamie Dimon and then Michael Douglas. Michael Douglas had both of them had oropharyngeal cancer related to HPV. And Michael Douglas struggled because his cancer was diagnosed late just because it was indolent and wasn't readily visible. So what is HPV? So HPV is a small circular DNA virus. There are over 200 types. The high risk for head and neck cancer are type 16 and 18. And about 80% of the Western population has HPV exposure. So it is everywhere and we all have it. HPV is the most common sexually transmitted infection. The prevalence in the United States is about 80 million, and the incidence is about 14 million. So again, it's everywhere. But the difference is whether we have the low risk or the high risk HPV. It is an oncogenic virus. So I know Dr. Chaturvedi sort of introduced this. There's pretty firm evidence that this is causative of cancer. And what it does is it affects the cells at a molecular level by changing the function of pretty important genes and proteins called P53 and RB. But this does transform our normal cells into malignant cells. And how does it do it? So either it enters our nucleus and hangs outside of our chromosomes, or it actually integrates into our DNA and then causes, again, changes at the molecular level, at the DNA level, the RNA level, and at the protein level. And where it inserts into our DNA is a bit random. You can see the distribution of the integration sites across the human chromosomes. And again, you can see it's not a recurrent insertion site. It happens randomly across our genome. So now again, the prevalence of oral HPV in the United States, so almost 10% of the US population has active oral HPV infection. I couldn't find these numbers in India, but it's probably similar. About 4% have high risk, so those are the oncogenic subtypes. And 1% has HPV-16, and HPV-16 is the one that's most commonly associated with head and neck cancer. And you can see here with 1% prevalence of HPV-16, which again is the high-risk HPV. So now we're looking at the incidence and the clearance of HPV. So you can see here in terms of the cumulative incidence of any HPV, high risk HPV, and then HPV-16, and then time to clearance of any HPV, high risk HPV, and HPV-16. And you can see the median duration of infection is about 7 months. And then this is the natural history of oral HPV infection. So I told you that HPV is very common and we all essentially have it. But it doesn't cause so many cancers, 80 million cancers. So again, the vast majority of people have exposure to HPV and clear the infection. A small percentage of patients have persistent infection. And even a smaller percentage actually have malignant transformation into oropharyngeal carcinoma. We don't understand why this happens, why some patients are not able to clear the infection, and why even a smaller percentage have malignant transformation. We talked about odds ratios in the earlier talk. For HPV-16 exposure and the risk of oropharyngeal cancer, it's significant. The odds ratio is 14 versus much lower in the other subsites in the head and neck. And how do we detect HPV? So there's a surrogate marker called P16. So we do immunohistochemistry. This is negative P16. This is positive P16. So this is at the histologic level. And then we can also detect HPV directly with in situ hybridization or with PCR. So these are fairly standard processes that we check for HPV in all of our oropharyngeal cancers. And in terms of the pathway, for oropharyngeal non-keratinizing squamous cell carcinoma, so this is pathologic specifics. We look at P16, which is a protein-based surrogate biomarker. And then one option is to look at directly at HPV using HPV DNA PCR. If the P16 and HPV are positive, we conclude that this is an HPV-driven tumor. If P16 is negative and HPV is negative, then this is not associated with HPV. There are some discordant cases, but these are fairly rare, about 5 to 10%. So if you're P16 positive and HPV PCR negative, this is probably not an HPV-driven tumor. And if you're P16 negative and HPV positive, this may be a bystander effect. So in the United States, in men, the HPV is the most common HPV-associated cancer is in the oropharynx. In women, the most common HPV-associated cancer in the cervix, but you can see pretty significant burden in the oropharynx also. And So HPV and head and neck cancer really came to the forefront in 1983. This is Dr. Syringen, who is a pathologist in Finland, who noted a similarity of the morphologic features of genital and oral HPV-associated lesions. And really based on the early findings, she raised the possibility again in 1983 that HPV may be involved in oral squamous cell carcinoma. So this is the incidence of oropharyngeal carcinoma in the United States. This is a SEER public national database. And you can see the significant percent change in men, in Caucasians, and then the different age ranges. And my next slide will show more specifics in terms of this basically exponential increase in incidence of oropharyngeal carcinoma that we're seeing in the Western Hemisphere. So now if you look at the oropharynx and then break it down into HPV negative and grayish black and then HPV positive in blue, again, you see this exponential rise in oropharyngeal cancer driven by HPV. And then if you look at it by gender and males and females and by the different age groups, again, there is an increased incidence in all of the age groups, but particularly in the 55 to 64 age range in males, and both the 55 to 65 plus in females. In India, the incidence and prevalence is a little bit pretty wide range. So this was a systematic review published in 2021 that searched databases over 25 years, looking at the prevalence of HPV, and you can see the significant variation in the range from 0 to almost 90%, with a cumulative prevalence of about 30%. We do know the prevalence is rising in India, and a little bit different sort of than what we see in Western Europe and the United States is there is no difference in survival for HPV positive compared to HPV negative. And I'll expand on this in my next few slides. So this was a publication in 2008. The top graph shows HPV positive cancer, and the lower line is HPV negative. And what we see is a pretty significant difference in survival, where HPV positive tumors do much better than HPV negative tumors. And this was further substantiated by a New England Journal of Medicine paper published in 2010, which demonstrated a 3-year overall survival of over 80% for HPV positive, P16 positive cancers versus HPV negative, P16 negative, and similar patterns for progression-free survival at 3 years were about 74% for HPV positive and almost 40% for HPV negative. So Dr. Chaturvedi also briefly discussed this. So because of the significant difference in survival, again, in the United States and North America and Western Europe, we are looking at de-intensification and de-escalation strategies to lower the toxicity while maintaining the excellent survival outcome. There's different ways to de-escalate. The backbone could be radiation, surgery, or chemotherapy. And there are multiple active clinical trials to try to find the best strategy to de-escalate HPV-related cancers. And most likely there's multiple different strategies that will be effective. This is just some published de-escalation trials. And again, you can see generally with de-escalation trials, we decrease the toxicity related to treatment while maintaining the progression-free survival and overall survival. So the goal is really to improve or at least maintain survival without hurting the patients long-term. And as you saw from the age groups, these patients tend to be younger, so have a life expectancy of 30, 40 years after the diagnosis of cancer. There are definitely new approaches to the oropharynx. So this is the Da Vinci robot, which really provides amazing access to the oropharynx. This was FDA approved in 2009. It increases or improves our visualization and increases our access to this site by allowing us increased range of motion and improved access and magnification. So this has really been a game changer in our field. So again, I think a major point of all of our talks, hopefully today, is that head and neck cancer is entirely preventable. So I say, do we already have a cure for HPV cancer? And yes, we do. So there's a very effective HPV vaccine that's available. This is the vaccine schedule proposed by the CDC, where routine vaccination is offered at the age of 11 to 12. Then there's options if someone is not able to get vaccinated at that age to get it in their early adulthood. And now this has been extended to the age of 45. So these are very, very effective vaccines. And again, I told you these numbers, about 85% of people will get an HPV infection in their lifetime. And the current recommended doses of the HPV vaccine is 2 doses for adolescents at 11 to 12 age. The dose, and I'll show you, is variable. There's some research trying to see if 1 dose is effective in preventing cancer. And sometimes if you're not vaccinated at an early age, then you need 3 doses. So the unfortunate part of HPV vaccination is the compliance of vaccination, and you can see it's about 50 to 60%, so not really acceptable. But we know, again, it is very effective. So patients who've received at least 1 vaccine, the oral HPV infection is almost 90% lower. So I'm optimistic. I think at least this is 50%, and we have a lot of impetus to improve the vaccination rate across the world. And this is some of the latest data I found out of India. So I couldn't find an exact number for HPV vaccination, but there are ground root efforts across the country. And the government is really pushing this, and this has been very effective for cervical cancer prevention and then head and neck cancer. But I think this is really the next step that's going to change the demographics of head and neck cancer is HPV vaccination. So in conclusion, HPV is pervasive. We've all been exposed to it. And fortunately, there's a very effective vaccine. There is an increasing incidence of HPV-associated oropharyngeal squamous cell carcinoma. It's more pronounced in Western Europe and North America, but we are seeing this across the world. There's complex interactions of HPV and our host genome. Survival and prognosis is improved, but it's not worldwide. So the question is, do we really try to intensify? And this is, again, significant efforts in North America and Western Europe. But again, the major point of all this is head and neck cancer, and more than 50% of cancers are preventable by lifestyle and risk factor modification. And then again, the other key is early detection, where when we're able to diagnose cancers at stage 1 and 2, the survival is significantly improved compared to when cancers are diagnosed at stage 3 and 4. So thank you again for this honor. Thank you. If you have any questions, please feel free to email me. Thanks.
Thank you very much, Dr. Agrawal. You have summarized this nicely. I have 2 questions for you and 1 comment. One most important take-home message from your entire lecture is that HPV-related cancers are preventable. We have vaccines. And this is part of national vaccination program in 86 countries, including one very small, our neighboring country like Bhutan. We are yet to include in our national vaccination program. That's 1. And number 2, this is just a thought coming to my mind, the way our entire country, I'm talking about India, has taken up COVID vaccination on war and food basis. Probably after a year or so, this all vaccine producing capability will not be that, they have to switch to some other vaccine. If they can do some kind of innovation and have mass vaccination like this, we may be cervical cancer free. In UICC World Cancer Leaders Meeting at Nur Sultan, I heard from Australia that they are going to declare Australia cervical cancer free with everybody vaccinated, all eligible people by 2028. I wish someday it happens for India also. So that's my comment. And there are two questions for you. Professor Shubda Chiplunkar from Mumbai has asked you that literature says that HPV positive head and neck cancers respond well to immunotherapy. Do we have Indian data on this?
Immunotherapy is approved as first line for recurrent metastatic disease. In terms of curative intent, HPV positive or HPV negative, it's still under investigation. The overall response rate to immunotherapy is about 20%. So I would say it's under investigation. And I don't know specifically about India, but I think it would be similar. The genetic profile, immune profile across different types of head and neck cancer, depending on different risk factors, seems similar. So I would think it would be similar in India versus the rest of the world.
Thank you. One more question is from Dr. Arpit Shah. He has asked, what is the cure rate of SCC spreaded to near lymph node of vallecula patient with no tobacco habit, and what is the recurrence rate in HPV or non-HPV?
So HPV related follicular oropharyngeal squamous cell carcinoma in a non-smoker, the cure rate would probably be about 80 to 95%. For HPV negative, which would make it either a stage 3 or 4, the cure rate is probably about 40 to 60%.
Thank you. Thank you very much, Dr. Nishant. Now I'll move to our next panel discussion. Since Dr. D'Cruz and Dr. Nishant and Dr. Pankaj Chaturvedi has highlighted that our majority of the cases are from head and neck, so it becomes our responsibility to look to answers to the question how to reduce this incidence over long run, because reducing the incidence is the key. So I welcome Dr. D'Cruz sir. With him, the panelists are Professor Ramesh Bilimaga sir. Sir is President-elect Indian Society of Oncology. He is past President ARI and Director SCG. Dr. Nishant, I have already introduced. With him joining Dr. Pawan Gupta, very dynamic personality, very, very active in anti-tobacco campaigns and entrepreneur as far as de-addiction is concerned. He is founder director for a company called Innovative Cancer Care Rehabilitation Private Limited. And Dr. Safalta Bagmar, she is a medical oncologist, senior consultant medical oncology at Max Institute of Cancer Care. So welcome all. I hand over to Dr. D'Cruz.
Thanks, Rajesh, and welcome to the panelists and to everybody who's tuned in. And I said when I started with my opening comments, a very important event on a very important day. We are supposed to run 6:20 to 6:55. I look at my clock, it's 6:35. So I'd request my panelists to be brief. We'll try to give the organizers back on time. As I was thinking what I should lead this panel on, the topic says how to reduce the incidence of head and neck cancer over the long run. I thought it's Friday evening. I could wind up this panel by just saying stop tobacco and we could all go for our Friday evening celebrations. But we have four very illustrious panelists, and I'd just open it up with one opening comment from y'all, and then we'll develop a discussion on that. Nishant, Ramesh, Safalta, and Pawan, if y'all can just make one or two opening remarks on your view on how you can reduce this cancer. Don't give a long discussion, a short point, and then we'll develop discussion on that.
Okay, thank you, Dr. Anil. This is Ramesh. 2 points I can tell you. One, and the point is we have luckily enough information and the scientific evidences as to the cause and for the cancer of head and neck. And we also know what are the necessary and preventive steps that one can take. One. Number two, now it has to be percolated to ground level, and it should be a people movement to handle this cancer and by preventing the causation. These are the two of my points.
So if I can develop on this point before I go to the other panelists. So basically you say tobacco, we know it's all tobacco, 90% of our head and neck is tobacco. So I'm going to throw this back to the four of y'all. And Rajesh, who made a comment that we should ban tobacco. So there are various methods by which we can decrease tobacco consumption. You could ban tobacco, you could increase taxation, you could do behavioral modification, you can do education. Where do we should put our bucks on? What would give us the best returns to decrease the consumption of tobacco? Pawan maybe, and then we can have a view from Safalta and Nishant.
Thank you so much, sir. And without taking much time, one very important thing is about tobacco is lack of education amongst the doctors. Amongst the doctors, I'm putting it very particularly amongst the doctors, there is a lack of education, and we have to stop. Most importantly is training and teaching the doctors about tobacco cessation, educating them how to help a person quit tobacco. And that is what we talk about 2AR, ask, advise, and refer. So the networking, that is what I call oral oncology connect between the dental and the oral oncologists, and also stopping the quackery about tobacco cessation and creating a nice, important, means educating the doctors that they should, to all the patients, they should talk about tobacco cessation and send the patient to the right cessation specialist, so that if we have more and more centers about tobacco cessation, automatically people will understand that yes, they need to stop tobacco and this is a disease and we should not go after the disease.
So Pawan, important points. You want us to have a focused education program. So basically a holistic program along tobacco to stop people from using it and have a strong cessation program. Like Mark Twain once said, it's the easiest habit to give up. I've given it up 99 times. I'm sure all of y'all have heard this refrain. So it is important to have a strong cessation program. Points well taken. Nishant, Safalta. In that order, if y'all could share your thoughts on this, please.
Sure. Thanks, Anil. Pavan, I agree with you, but I think this has to start earlier than when we see doctors. You know, human nature is very difficult, almost impossible to change, and we're still malleable when we're young, when we actually listen to our parents and teachers. But at this age, I'm not going to listen to anyone. So I really think education, starting at very early ages, about the dangers of tobacco are really essential to make a long-term effect.
Safalta, your views?
Yeah, I fully agree with Nishant. In fact, at every step we should take care of it. Yes, when we ban tobacco, it will be like increasing a black marketing of thing. If we increase taxation, it will be more of the money that will be involved from the family. but the person who is being addicted to the tobacco, he will somehow he will get the thing. So it is like from even from the school time, in fact at the teenager time, we have to educate people, and at every level in colleges, and yes, to increase the tobacco cessation program, because it's very easy for us to say stop tobacco and from tomorrow, but it's not possible for a patient. It's like, it is like after a while they restart all these things. So at every step we should take care of it.
So I think some very important points from all the panelists, and I'm just going to recap this. Nishant made a compelling point about asking people to, or guiding people never to take this habit. And they say, if you can work on people between high school and college, and they don't take to the tobacco habit by 19, there's a 90% chance they'll never become tobacco users. So I think the point that Nishant makes is very compelling. And those of you all who are in the field, you need to focus your resources on this very, very captive group of our youngsters, and they should be taught not to use it. Banning, I'm absolutely, I mean, you can ban it, but it's so difficult to implement. We banned the use of these pan masalas in our country along with tobacco, but you can still see them being sold all over. Banning is very difficult. But again, Bhutan was the first country to ban tobacco. People continued to use it. They brought in a draconian law where they said that you'll be arrested, imprisonment. 25% of Bhutanese still continues to use tobacco, and they have a very tough border. The border with China cannot bring in, the smuggling came in from India, and the first man they arrested was a Buddhist monk. I said Adam sinned, he couldn't when it was banned, and now you have a monk that's sinning, so banning isn't well. But the point that is very, very compelling, and we have a New England Journal publication, Prabhat Jha's group, that if you raise taxation, you will have decreased consumption. The most how should I say, the most effective tool. And what South Africa and France did in a decade, the US took three decades to accomplish. And even in the US, if you see California versus the rest of the US, California upped taxes, had decreased consumption compared to the rest. So those of y'all who have a voice with people who influence policy, taxation is the way to go. And unfortunately, in our country, they tax cigarettes, but the low-cost products, such the BD and those little pouches that you get, do not have significant taxation laws on them. I'm a strong advocate of that. Ramesh, I can see you're dying to make a comment. Please go ahead.
Yeah, this is regarding Nishant's comment. That's a very good comment. That's on the, teaching the students, the youngsters, and before they actually start smoking. That is a school program. In fact, in India, and there are quite several states have a school policy on tobacco usage. And if you see, quite a lot of, in our Karnataka state, schools have put up a board in front of their, the school that is a smoking for tobacco or usage of tobacco inside the school, the premises is banned. And they also teach. And in that context, I want to tell you, now we have one now for the NGO called Foundation for Sustainable Health in India. And when I'm the president for that, and we have adopted 2 district schools, and 28 schools we have taken up for our educational program. And there we teach them, and we give them modules, and teach teachers there, and give them a book on the tobacco cessation and also substance abuse at that age. And school health program. And I really feel these kind of a program, and I'm sure many people must be doing that too, and must be popularized and help the government also, which they have a policy already in line.
Thanks, Ramesh, and congratulations for the great work that you're leading. Pawan, comment from you, and then I can see Rajesh's hand up as well.
Thank you. See, what we did was a Save the Youth campaign. And it is like a sustained effort. It is just not going once to the school and giving a lecture and coming back. Creating tobacco marshals in the schools, from the teachers, training them, and then asking them to, because the new batches will keep on coming. It is not taking the time of the patient or the doctors or from, it is training the masses that is going to help. And that is where we made tobacco marshals, tobacco ambassadors, and tobacco specialists. And the three very important, it is just not the schools. The three important factors that we have to take over is be smart, do not start. Jagruk rahe, prarambh na karen. That is in the school program. And we have a comic book for that. Win over tobacco made easy. That is for those who are taking tobacco, we have to tell them, we have to create and sensitize them. They need to quit tobacco. And the fourth, those who are not taking tobacco, for them, be careful and fearful of the people who are taking tobacco around you. That is for the second hand, third hand, and the fourth hand smoking. All the three programs together can actually create. That is where we have to create an outrage against the tobacco users. For the people who are not taking tobacco, they should look at the tobacco users uglily. That yes, if you are taking tobacco, you are not fit in the society. So that creating that ripple in the society, that is where the education has to go on. And that is where we have to create a lot of doctors who can create a network of people in the society, of the marshals, of the ambassadors, and of the specialists. That is what is going to create and of course, another very important thing is having number of oral care and tobacco cessation centers across India. Every corner we should have an oral care and tobacco cessation centers where the person who wants to quit tobacco, see the data says almost 70% of the people who are taking tobacco want to quit tobacco. So they need a place where they can go and where there are trained doctors who can actually help them with a good result. That is what is, I feel that is something that is going to really make a difference.
Pawan, you made many compelling points, but my take-home message from all what you said, one, you should have passion, fire in your belly. When you speak, I can make that out. All of us sit on panels, talk casually. You need that fire in your belly. And second, you must have a holistic program. These are just the two important points I'm taking back from all what you said. And I congratulate you on your efforts. I've been part of some of them and I've followed your progress. We need more warriors like you, more heroes like you to help us in this. Rajesh, a comment from you, please.
Sir, I have two things to say. One, you made a comment regarding the taxation, you increased the taxes. So over 1,000 plus international airports across India have a display of costliest tobacco products and it is getting sold. Government loses taxes and the most people who can afford the costliest thing, they buy it in bulk for themselves and for their friends and family. Earlier, this limit was 400 cigarettes in India. We have returned to Prime Minister 4 or 5 years back. And now, I think last year or before last, it has been brought down to 100 cigarettes. So probably this, if all countries, they stop this on the international airport, this is one point I wanted to make. That is, and the second point, if the cultivation of tobacco, if can be affected, I was discussing the other day with Dr. G.D. Patel, he is here, that we are living just 50 kilometers away from entire tobacco belt of Kheda and onwards. So if we go and talk to the all people who are, one village we take up, only one village at a time, and we talk to the tobacco growers, and if we can mobilize them to switch to the other alternative equally rewarding crop, maybe oil crop or something which is equally rewarding for them. So production will be affected in some year down the line. So these are two comments.
So Rajesh, good points. Again, there are multiple things that we can do, and I guess we can keep talking till the cows come home. But at the end of the first segment of this panel discussion, let's all conclude, all four panelists strongly voice that we must have a holistic approach towards tobacco cessation and decrease tobacco consumption. And I'm going to add another point that please, in our country, we use the supari, the betel nut, the areca nut, and that is a carcinogen, and somehow that is underplayed we must remember that that is on the IR list of carcinogens, and our fight against this is also to be focused on the supari. The reason is, if you look at people in our country have submucous fibrosis, and you look at data, people who have more areca nut per bite compared to the tobacco have a higher incidence of submucous fibrosis. So please keep that at the back of your mind as well. It's a combination of both. I'm going to switch now to early detection, because I know prevention is tobacco, no alcohol, clean mouth, and all that kind of thing. But I think also what's important is we must talk about early detection. What, according to y'all, again in no particular order, I'm asking my panelists, just put your hands up and then you can go ahead, is the best approach? Should we have a national screening program? Should we do mouth self-examination on the lines of breast self-examination, and we've got data from within the country? Should we go and shine a light in everybody's mouth? Should we take photographs on SMS and then send them to experts? Your quick view on early detection. Pawan, your hands up. You can go again first.
Yeah. Simple, what I believe is creating awareness, and that is what I did among the masses. Chota Dana, that is what I said, a Chota Dana campaign. जब भी देखो छोटा दाना, उसकी जांच जरूर करवाना, कैंसर को बनने ना दो नासूर, जल्द करो इसे दूर. So it was a campaign for the masses that please do examine your oral cavity once every month. That is a simple thing that I started, and believe me, I have got a lot of patients coming up with very simple, very small lesions, 0.5 centimeter lesions, which can be just excised. That is one of the campaign which I am running, and it has been, of course, training the doctors. That is the second thing. The dental people, they have to be looked in, and that is what we started an Oral Oncology Connect education series, where we started networking with the dental people, and we started training them so that they don't just look at the teeth, but they look at the whole mouth. That was the two things that I wanted to put in. Thank you.
Yeah, but good points. But I think I just urge you that when you do these programs, if you can do it in, again, a more holistic way, have some data out there which will convince some Puritans to take it up in a, maybe government might take it up as a policy that when you get dentists. But your point's well taken. Ramesh, your points, please.
Yeah, that's right. I know. I feel it's just a combination of everything, and we must synergize our work. The government has the National Cancer Control Program, and also they have in their health policy of 2017, and they have also earmarked quite a lot of funds, and in every PHCs for examination of the oral cavity and other equipments are. In fact, today I was just going through one of the data that was presented for the Northeastern the part in the data. They said 90% of these PHCs has got the equipments and to see them are the facilities, but the personnel are not enough to examine them. In other words, use the government provided facilities. One, use NGOs. Use NGOs, and they are our really the right and left hand to make this policy going. And the third one is the existing facilities of be it a private or a government. Make use of that in detecting early detection of the cancer, and is quite should be used. The last and for which is a combination of all that, the the oral examination, which is a people and a participation. So governmental participation, NGOs participation, and the healthcare providers participation. Finally, it should result in the people participation, and this is the one which finally drive the screening program, successful screening program.
Thanks, Ramesh. Safalta, your voice. All the audience are telling me you're not asking Safalta any questions. So please, your turn now.
If it is multiple choice, yes, all the choices. But if it is a single choice question, then in that case, I would like to implement the self-examination thing, because that will create a fear among the people that they will examine. They will be able to see themselves daily, and that will create a fear and awareness. So I'll put my bucks on the second point.
Okay, so I think these points are well taken, but I'm going to make a comment and then turn over to Nishant, who's the guru in the lab on all this stuff. Nishant, we do self-examination. You send health workers out to look into people's mouth. Our group from Trivandrum, Bobby Matthews, led this study of sending school students, college students, and he looked into the mouth of people and did show some kind of drop in figures. The problem in the oral cavity is when you look in, all of us have some sort of discoloration on the gums, poor hygiene, there's a little granulation around your. If you do the self-examination, you'll be running into the hospital, we'll be inundated by people. Your views, Nishant, and I want your views also on things like salivary diagnostics and the Visi light and various other things. If you can make some comments on that.
Sure. So I would say screening is imperative in India, given the high burden of incidence and prevalence of head and neck cancer. So it's akin to colon cancer screening with colonoscopy, mammograms for breast, low dose CT for lung, and PSA for prostate. So again, India needs a screening effort. I think self-examination is great, but also engaging dentists and primary care physicians. In terms of adjuncts, the Visi light, none of these have been endorsed by the ADA because they're not really that useful. When we do self-visualization, again, you'll have a lot of sort of false positives. And then if you have an NGO going out to sort of remote areas, there'll also be a lot of false positives because you need a little bit of expertise in this matter. So there are other salivary diagnostics that are emerging, and we're developing one also. The prohibitive part of these things is the cost. Depending on the technology, they're fairly expensive and relatively expensive. So our goal will be to develop assays, salivary diagnostic assays with very high sensitivity, specificity, but really cost effective. And I think we'll be there in the next few years.
So interesting. That'll be lovely that as we walk past, maybe at the airport, you have the little kiosk, spit in there and you'll get your report by the time your flight lands up that, hey, you're at high risk. There are some mutations, go see your doctor. That would be wonderful. But coming back to screening, if you look, the only study with mortality as an endpoint came from our country, Shankar Narayan from IARC with the Kerala guys. It's called the Kerala study, where they showed that you do save lives in high-risk individuals, tobacco, alcohol users. And they reanalyzed their data last year, published it in JCO, looking at only the people at the highest risk. So looking at the numbers to treat. And they showed if you look at the 50%, the 50 quartile, which is at the highest risk, you need about 2,000 screens to prevent one death if you look at the entire population. But if you looked at high usage of tobacco, the number dropped to 610. And this data has now also come for breast. So when you don't have much resources, it's difficult to have a national screening program in our country because we just don't have that strong primary healthcare system. It's better then to focus on high-risk individuals. For every 610 screened, you'll save one life. Back to the panelists, any other thoughts you have on how we can prevent or reduce the incidence of head and neck cancer? And now, not theory. I want some out-of-the-box stuff. Prime Minister should wake up and say, hey, Ramesh, that's a great idea. Where were you all these years? Or a health minister should say that. Any one of the four panelists in any particular order. Go, Pawan. Pawan's got the idea. You go first.
Thank you, sir. Right now, where I am sitting is an oral care and tobacco cessation center, which we started at the Max Hospital. And what we started was training or educating the cardiologists, the pulmonologists, the obstetricians, and most of the high-risk patients come to them. So setting up of tobacco cessation centers and oral care centers and training the neurosurgeons, oral surgeons, cardiologists, pulmonologists to send the patient for screening, at least for the oral cavity, and doing it oral care, that has made a lot of difference.
Lovely. So Your thing would be to educate other doctors and keep them great. Ramesh.
That's like making them alliance partners with our oral care program.
Lovely. Point well taken. Ramesh.
Yeah, the only one point I can tell is the vendor licensing. Right now today the tobacco is available anywhere, everywhere. The moment the vendor licensing is introduced, and even the age of the person who can the avail this is rise to 21 years, and immediately, and we can see quite a lot of change and in the tobacco usage.
So I think another very important point I always say in our country, if you don't have a job, two things you'll never be out of a job: either open a pan kiosk or dig a road. There's always some construction happening, or you can have a pan kiosk at every street corner. Points well taken. Licensing sale of tobacco. Safalta.
So what I think so is that, like, in our country, we don't have the paramedical training for the general citizens. So what I think is that in 11th or 12th, we can include a branch for all the students that will train a person, a student, that if you see a person who is having chest pain, or if you see a person having seizures, you should be able to take care of that roadside. Similarly, they should be taught about self-breast examination, oral examination. So that will create awareness of overall health in a student, and that will be carried on when they become a citizen. And second thing, HPV, inclusion of HPV vaccination in national immunization program. These are the two things which I vouch for.
Excellent. Again, excellent points that we must have health education as a priority. I think we are getting there as our standards of living improve. Health is become an important point on the agenda. I'm sure it will happen. Nishant, you've grown up here. You're now there, so you know the best of both. Some advice for us.
Yeah, I think this is a public health effort, and I think it's public information. So I would say some of the most influential people in India, so the Prime Minister Modi, Amitabh Bachchan, Ramdev, and you, Anil, should make public statements, right? Like, just say, put it out there, be very succinct and clear, and say, do not smoke, this is bad for you. Do not use pan masala and the other chewing tobacco products, this is bad for you. And I think if you send this message, people will catch it. This message has not been clearly dictated in India, and it needs to be very clear. And I think Pavan has some really nice ways to sort of have this message portrayed.
Yeah, so point well taken. And I think we are getting there. Now we do have people who are proactive in the media. If one of our celebrities endorses a product, there are people who will go hammer and tongs behind them. One of the names you said did endorse some product years back, and a big group went against him. So if I had an idea, I would say this. We congratulate our Prime Minister, people in office, for what we call Modi Care, where they give it may be a limited funding, but a lot of people below poverty line do get a funding for healthcare in our country. And I think it's a very strong and a very positive first step. But I think that amount should now be broken into two components. You can only get your 5 lakh Indian rupees. 10% of it should be on wellness. If you've not been coming for your checkup all these years, once a year, to have your pap smear, to have or visual inspection of the cervix, your mouth looked at, then you don't get your 5 lakhs. So that would be my out of the way box. And those of y'all who can influence people in policy, you must tell them that 10% should be for wellness. And then we'll pick these early cancers up, and we'll be able to have patients with curable disease. I think we've had a wonderful discussion, great inputs from all 4 panelists. Any concluding remarks, or I'm going to hand back to Rajesh? Okay, I can see Lalit and Dr. Pankaj clapping. That means that closed the panel discussion. Pawan, go ahead.
Pawan, yeah.
Just one thing, that is educating the doctors That is my first thing. And setting up of multiple tobacco cessation centers at all places. That should be one very important thing, that all the oncologists should start doing it. That's my, thank you.
Okay. Doctors who are listening and who are participating, Pawan has a grouse against you all guys. You all aren't doing enough. Educate yourself. So we're ending on that note. And Rajesh, back to you in the studio. Thank you for having me and my 4 panelists. I enjoyed the session and learned a lot from the 4 of them. Thank you.
Thank you.
Thank you very much, Dr. D'Cruz
Thank
sir, Dr. Bilimaga sir, Dr. Gupta sir, Dr. Nishant sir, and Dr. Safalta. Very, very innovative ideas have come out of this panel, and for government, I think we should submit in the form of a white paper. The one idea I'm impressed with, Dr. Bilimagas, that if the licensing of tobacco products start happening like this liquor shops, the entire scenario of this will change, and probably our finance minister will be able to generate more funds. And so with that, I thank all panelists once again, and I invite our next panel for the next panel discussion. Our next panel discussion is on the UICC theme, Close the Care Gap, how we can contribute in all different cancers in terms of prevention, early diagnosis, treatment, and all other different aspects. And we have a very dynamic, active moderator here, Dr. Lalit Mohan Sharma. Sir is Senior Consultant Medical Oncologist and in charge Pediatric and Preventive Oncology. In fact, I would say preventive oncology is focus area and passion. Very recently, in one of the family marriage, his family marriage, we met, and my family was surprised that 1 hour we kept on discussing only on the preventive campaign, what next we should do. So that is the passion he has. And sir is assistant professor in Department of Medical Oncology, Mahatma Gandhi University of Medical Sciences, Jaipur. Along with Dr. Sharma, we have panelist Dr. K.S. Gopinath sir. He is Director and Consultant Surgical Oncology, BIO, and sir has been holding many national and international posts. He is has been honored Padma Shri by Government of India, and he has led different associations also in different capacities, including the Asian Clinical Oncology. With him, we have Dr. Pankaj Shah sir. He is a Padma Shri awardee, and he is Vice President, Gujarat Cancer Society. It is the largest NGO who has its own medical college and cancer hospital and so many things. Dr. Pendharkar is traveling deep in Tashkent, Uzbekistan for his camps. So we may not be having him as connectivity is poor. With him and the other panelists, we have Professor Dr. J.D. Patel. Sir is Senior Consultant and Oncosurgeon, Head Apollo CBCC, and Assistant Professor Surgical Oncology, GCRI. Mrs. Vandana Gupta, Founder and Chairperson, We Care. Very, very dynamic lady at national and international forum, very vocal for patient advocacy, and always ready to help me and all cancer patients, whosoever goes. And we have guest Dr. R.N. Meena sir. He is State Nodal Officer, NPCDCS, Government of Rajasthan, Jaipur. I hand over to Dr. Sharma sir.
Thank you. Thank you so much, Rajesh, for the kind words. And I'm truly excited with the discussions in the previous panel discussion. Dr. Pawan, Dr. Anil, and all other participants, they had extremely good inputs. And now we will be continuing almost the same discussions, and we try to generate some new ideas. So the first foremost thing is about what you shared about the person family function in Ahmedabad. I went to Gujarat Oncology, that community center also. I could see Dr. Patel's and Dr. Pankaj Shah's great efforts. I visited all the posters and I clicked pictures of almost all of them. Dr. Geeta Joshi showed me about the overall how they are functioning. I visited the palliative care also, and hats off to your dedication and the hard work you all have pumped in. Probably that is the best oncology cancer center, community oncology center in India. This is what I personally feel. And I had a great desire to visit that, and it was fulfilled last month, in fact, for a social reason. So with this small background, let me start with Professor Pankaj Shah, sir. Sir, you have seen a whole era of oncology from beginning to till date. So what do you feel, what is the most important point where the outcome is still poor in developing countries and LMICs?
Outcome is poor because of the, my throat is not that well. As usual, for the last 50 years, we are talking that we are getting late cases. Recently, what I observed in the last 5-6 years, that we are not getting that very punctuated and big masses now. We do get just patient in the early stages. So change is seen, but it is not to the satisfaction of all of us. What we want is really a good number of the people who can be diagnosed in a curative state. And that too, we should have a team to cure the people. Before 50 years, handful of surgical oncologists, very few hospitals. Now, we have got a battery of infrastructure available in the country to take care of them. So scene is definitely changing, and we have a more facility, more infrastructure, and it is increasing day by day. And what I see that in 50 years in Ahmedabad, now we have got 6 to 8 radiation centers. There was only one in the whole Western India, apart from the Bombay, for a long time. So every city is flourishing, and the cancer care and the basic healthcare scenario is changing. Now,
very true, sir.
Considering the efforts, so I feel that the future is bright, and whatever the infrastructure which has developed in the country is going to help us in a big way. I would like to point a little bit early what Anil said about Narendra Modi. And his vision is the digital health India. And that will make a great difference in prevention of many diseases. If every Indian, like an Aadhaar card, has a health card, all the information can be passed on to the person individually to keep himself healthy. And I endorse the idea of really giving those who are having a bad habit or bad health lifestyle, they should not be given that 5 lakhs or the PMJ Yojana after the 5 years. Once everybody knows that it is all bad, why to give unnecessary spend money on a disease which is invited by the civilian of the country? So what I feel two things. One is that scenario is changing. We have got it. You have visited our oncology community oncology center. So we have got 2 halls there, a hall of grave, you see, a very advanced disease photographs, and the hall of heaven, where the patients which are treated with the surgery and radiation therapy, and they're cured and living for many years. Now the hell of grave is going to now becoming smaller and smaller, and we will have more and more people with a curative intent treatment, even in head and neck cancer. Thank you, Lalit.
Thank you so much, sir, for your kind words and the real insight of the problem, in fact. So the next comes that whatever I could gather from the developing world data and the difference in the developed world versus developing countries, the major impact in the cancer outcome is probably not because of advances in the treatment. It is probably because of early detection and the screening methods. Professor Patel, sir, you are amongst one of the senior most surgeons. So can you highlight that how can we achieve that, or is that true that the major science is focusing towards the treatment part, less is focused on the prevention and early detection? You need to unmute yourself, sir.
Yes, sir. Actually, you are right, sir. Actually, what Dr. Pankaj Shah sir said that, initially we had a lot of problem in having facilities who can treat. Now there are plenty of facilities who can treat, but now there are very small amount of people who are working for preventive oncology. Say, we say that biopsy is very easy. You can go 5 kilometers, you will get a cancer surgeon. In Ahmedabad, there are 105 cancer surgeons. But what I would like to say is that we have to increase the amount of education to the people. So what Pawan said in the first session was right, even though we are doctors who are intent to cure the cancer, we are basically, I'm a cancer surgeon, you are a medical oncologist, but we are the only guys who are working for education of the people. Instead of that, what I would propose is that why not university guys, the NSS student, the other students are taken as a volunteers, and we train them, and they subsequently train the people for early diagnosis. And that is the most important thing. Unless we do early diagnosis, probably I think this battle looks very difficult.
Absolutely right, sir. Well said, sir. And Dr. R.N. Meena sir is here. Dr. Meena sir is in the government setup, and Rajasthan is in fact has got highest COVID vaccination record, and the theme of the current government is Nirogi Rajasthan. So Nirogi Rajasthan means we don't want to see diseases and everyone should be healthy. Professor R.N. Meena sir, can you highlight the government efforts जो चिरंजीवी स्वास्थ्य योजना चल रही है उसके तहत कितना फायदा हो पा रहा है आम आदमी को?
सर नमस्कार।
नमस्ते सर।
सर राजस्थान में माननीय मुख्यमंत्री की जो परिकल्पना थी कि पूरा राजस्थान निरोगी राजस्थान के रूप में रहे, तो इसका निरोगी राजस्थान माननीय मुख्यमंत्री महोदय की बजट घोषणा थी। उसमें जो भी नॉन कम्युनिकेबल डिजीज से संबंधित थे उनके आईसी कैसे कर सकते हैं, अर्ली डायग्नोसिस कैसे कर सकते हैं, और इस परिप्रेक्ष्य के हिसाब से निरोगी राजस्थान, इसके पहले रूप से यूनिवर्सल हेल्थ कवरेज के हिसाब से भी राजस्थान में जो चिरंजीवी स्वास्थ्य बीमा योजना थी, जिसमें पूरे राजस्थान के सभी लोगों को इस योजना के अंतर्गत कवरेज किया हुआ है। इसमें 5 लाख तक के जो क्रोनिक डिजीज या सीरियस डिजीज है उनको निःशुल्क इलाज करने का प्रोविजन है सर इसमें। और जैसे कैंसर के क्षेत्र में यदि देखा जाए तो राजस्थान ने पॉपुलेशन बेस्ड कैंसर रजिस्ट्री अभी स्टेट गवर्नमेंट और आईसीएमआर बेंगलुरु के बीच एमओयू हो गया सर, और पूरा राजस्थान की पूरे सभी स्टेट में पॉपुलेशन। सर आवाज आ रही है?
यस सर, यू आर ऑडिबल सर।
सर हाँ सर, उसमें पॉपुलेशन बेस कैंसर स्क्रीनिंग रजिस्ट्री मैकेनिज्म हो जाएगा सर। राजस्थान पहला स्टेट है जहाँ पे कैंसर को नोटिफाई, शायद और स्टेट भी हो सकते हैं पर यहाँ पे भी कैंसर को नोटिफाइबल डिजीज के रूप में वो किया हुआ है सर। इसमें जितने भी हॉस्पिटल है उसको कैंसर के जो भी पेशेंट है उसको सूचित करना उसको आवश्यक है सर। सर इसके साथ साथ सभी डिस्ट्रिक्ट हॉस्पिटल में डिस्ट्रिक्ट के वहाँ पे जो मध्य प्रदेश के पैटर्न पर डॉक्टर पांडेकर के मार्गदर्शन पर सभी जिला चिकित्सालय में डिस्ट्रिक्ट कैंसर केयर यूनिट स्थापित है सर, और उसमें फॉलोअप कीमोथेरेपी, पैलेटिव केयर, ये सब सुविधा वहाँ पे उपलब्ध है सर।
सर जो अभी अपने राजस्थान में चिरंजीवी स्वास्थ्य योजना चली है उससे नॉन कम्युनिकेबल डिजीज का अर्ली डायग्नोसिस में कितना इम्पैक्ट आ रहा है, उसका एनी क्लूज की कितना फायदा एक्चुअली हो पा रहा है ऑन अर्ली डिटेक्शन?
सर अर्ली डिटेक्शन मतलब सर दो चीज है। चिरंजीवी स्वास्थ्य बीमा योजना जैसे आयुष्मान भारत के 2 पिलर है सर, एक हेल्थ वेलनेस सेंटर और एक क्यूरेटिव पार्ट सर। तो क्यूरेटिव पार्ट है सर वो एज ए चिरंजीवी स्वास्थ्य बीमा योजना, जैसे आयुष्मान भारत में तो पर्टिकुलर ग्रुप को उसमें सम्मिलित किया सर। इसमें चिरंजीवी स्वास्थ्य बीमा योजना के अंतर्गत पूरी राजस्थान को सभी यूनिवर्सल हेल्थ कवरेज है सर इसमें। तो इसमें तो डायग्नोसिस और ट्रीटमेंट का पार्ट है सर। अर्ली डायग्नोसिस के लिए तो ये कि सर यहाँ पे है जिसमें 3 तरह के कॉमन कैंसर है सर, उनकी स्किन सम्मिलित है सर।
Right. Thank you so much, sir. Vandana ji, now I'll switch over to you because government अपना काम कर रही है, but NGOs are equally involved in various fronts for the cancer care. So how about the prevention and early diagnostic part? Treatment में तो बहुत help मिल रही है NGO से, we all agree. So can you highlight कि prevention and early detection में कैसे NGO help कर रहा है?
गणमान्य अतिथि डॉक्टर से बात करने के बाद I don't know what I can add on, but I know a couple of things which I think if implemented can make a difference. One is that if we have we know we have a large population of rural patients, and in the rural areas the sarpanch is the most important person. So if the sarpanch takes on this responsibility that in his village people will not consume tobacco, and he has to, along with the help of ASHA workers maybe, train the people that there's going to be no tobacco at all in that area. And we as NGOs can, work along with the doctors to go into those villages and talk and explain to them why we are saying that it is not good to have tobacco. And then also maybe encourage them to come along with us for checkups and, like either visual checkups or bringing them to the hospital or something. So that is one thing that I feel can be done. The second thing I feel, we had gone to a small industrial area and we had spoken to children about tobacco and its harmful effects. Unfortunately, the thing is, that we can only say that these are harmful, but there is nothing to prove that only tobacco can give you oral cancer or only having too much of alcohol can give you cancer or something like that. These are something which can increase your risk of cancer. So that is something which we need to explain to them. And when we spoke to these children about it, there was no plan to talk to their parents, but almost all the children came and said, our parents are using these products. We know that it is harmful, but we find it difficult to talk to them. So when you're talking to us, please make it a point to talk to them also, which means that children understand and they know that they are not capable of stopping their parents from doing it. So we as NGOs should, whenever we are conducting a workshop or conducting a prevention and educational talk, should also include parents and have the children say something about it, so that the parents understand that coming from a child, it's always understood better, but the child does not have the like उतनी हिम्मत नहीं है उनको कि अपने पेरेंट्स के अगेंस्ट कुछ बोल सकें. So I think that would make a lot of difference in creating a lot of awareness and putting them to go for their prevention and checkups and all that. Because we have seen that in taxis in Mumbai, it was said that nobody can smoke or use tobacco products while you are in the taxi. So when we ask the taxi drivers, they say that the passengers just say, you drive your taxi, you get your money and period. Nothing more than that. Don't even contradict us or don't even ask us to stop it. So, these are rules which don't come into implementation stage at all. And I agree with the Ayushman Bharat thing that a family has any who is chewing tobacco, let alone, he may not get cancer. But even if he's using tobacco as a product in the house, then that whole family should not be given that the facility that the government is spending on, because then it will become like a realization that because the family is having tobacco, this is what is happening. And as NGOs, we always encourage people that when we are talking to them, and if we can make somebody quit tobacco, we've tried it ourselves, that you say that whatever tobacco you are spending money on, put that money in a box, and at the end of the month you see how much you have collected. Maybe that will motivate you to give up the tobacco products. But also, if you have understood what we are trying to say, then make it a point that 5 people will be educated by you. So each one becomes an ambassador to educate. We don't have to have hundreds of people going there and all that. But if there's one person who has understood and he can explain to 5 more, and those 5 more can go on to another 5 more, I think very soon we will get this result that we are looking for. And I think, but NGOs are always there. They are happy to work with the doctors, provided the doctors want to make us a partner and collaborate with us.
Lalit Kumar.
Thank you so much, Vandana ji, for your excellent word. And Dr. Kiran Majumdar Shaw is with us. And Madam has done a lot of good work on various tobacco related and various social projects, of course, mainly in the Bangalore city in Karnataka. So Dr. Kiran Majumdar Shah, may I invite you for your few words about on the World Cancer Day?
Yes, so thank you, Dr. Sharma. First and foremost, on World Cancer Day, it's a great privilege for me to be part of this conclave on head and neck cancer. And as all of you have very rightly said, this is a huge socio-economic disease burden for India. And I think we need to do a lot right from even before early detection. I think this whole focus on awareness creation, on tobacco cessation, it all starts with that. And I must also share with you that apart from developing drugs for head and neck cancer, Biocon has actually partnered, with this very important initiative on tobacco cessation with the Oncology Task Force, which is headed by Dr. Rath. And we have been doing this for many, many years to see how we can basically bring attention to the evils of tobacco use. And we have been at it for a long time. But apart from that, as you know, like everyone has said, it starts with early detection. And once you have early detection, it's very curative, as you very rightly mentioned. And of course, if it goes beyond that, then we also have to look at newer ways of treating these cancers. And as a company, we have been very, very focused on immunotherapy, because we do believe that a combination of immunotherapy with chemo and radiotherapy has played a huge role in really reducing head and neck cancer and the very nasty impact of this particular cancer. Now, as you know, this is a cancer where we have 200,000 cases of this cancer every year in this country. And whilst we try very hard to reduce this burden, we do know that it's a growing challenge for us, and it does require the coming together of multiple efforts of awareness creation, of early detection, of timely intervention, and of proper managed care. And I think all this is going to help us to fight this particular cancer. In addition to that, I think it's also very important that we talk about the power of technology. And I think digital technologies are going to play a very, very important role going forward, whether it is detection and diagnostics, whether it is treatment paradigms. I think, data science, data analytics, AI, and many other kind of technological, interventions are going to make a huge difference to the way we manage cancer. And so we are very excited to be part of this whole digital world. And as someone said, I think the Prime Minister has very rightly focused on the National Digital Health Mission as a very key area for both wellness and health. And I think this is something that we really need to look at in a very, very cohesive and collaborative way. Just a thought I wanted to leave with all of you is that India is a country that really needs to focus a lot on translational research and clinical research. I think we have a huge ecosystem of clinicians, of researchers, of patients, of caregivers. I really think we need to leverage this and create new knowledge. We need to come up with new treatment regimens. I think there's so much we can do with these cancers, and especially head and neck cancer. As far as our company is concerned, not only have we focused on research and innovation, as many of you know, we have actually developed a novel biologic, which is nimotuzumab, which has really, been used extensively in treating patients with head and neck cancers, and in a very efficacious way, if I may add. And I think what is important for us is to generate a lot of clinical information, knowledge with some of these new drugs, especially when we have access to these new medications, and really come up with new, medical wisdom that can allow us to shape our own treatment regimens. So as a company, we have always focused on new drugs. We also have bispecific antibodies that are coming up for head and neck cancer, which I'm sure we will. At the moment, it's being trialed in the US, but I'm sure very soon we would like to bring it to India to try and see how we can use some of these new ideas and new molecules to really improve the outcome of patients of head and neck cancer. As you know, we've also embarked on biosimilar cancer drugs, and we've been extremely successful. In fact, we were very proud of the fact that we were the first company globally to be approved for our biosimilar trastuzumab by US FDA. And we continue to develop a pipeline of biosimilars and novel drugs. So I look forward to this very close partnership with all of you, where I think we need to focus on on many of these research opportunities. And as I said, we have some exciting research efforts. We have a very interesting pipeline of products where we have products which are like biosimilars. We're looking at new targets apart from EGFR, which is the conventional old target. And I think it's going to be very, very interesting to see how we can basically start becoming an important part of the research and innovation system globally. So I really want to wish all of you all the very best, and thank you for giving me this opportunity for making a few comments at this very important discussion.
Thank you so much, Dr. Kiran Majumdar Shah, for your excellent words. And we are really thankful to you and your team of Biocon for giving us a lot of biosimilars, which are world's one of the best top quality products we are able to use in India at affordable prices. Can you highlight a little bit more about the AI-based technologies to use for head neck cancer, especially? I have seen few publications where Biocon has been the main body.
Well, this is a new area, Dr. Sharma, and I think we need to look at a lot of the data that is being generated. And we need to look at a lot of, today, of course, AI is being extensively used in interpreting scans, as you know. So diagnostics is the natural area where AI is being used and applied, and interpreting data, that is patterns and data, and being more predictive and more exact in terms of its diagnosis in a very short period of time. Because as you know, any of these diagnostic scans very often it has gray areas of interpretation. And we hope that, with the use of new technologies like machine learning and AI, that we will actually start getting into precision diagnostics, which gives us a lot more, predictive and precision information about any kind of cancer. But these are early days. I would say that we need to really focus a lot on much richer data. Right now, the data itself is very sketchy around the world. So I think you need normalized data, you need much greater data. But India is a country that can do it. India has the software capabilities, India has the data science capabilities, and India has the kind of opportunity to create a platform for collecting all this data in a normalized way. We've done a great job, if you think about it, on the vaccination front, where the CoWIN app actually collected a huge amount of vaccination data, like no other country has been able to do it. and except that we ought to use that data, connect it with the RT-PCR data and the genomic sequencing data. And if we could do that, you would get some very deep insights into COVID itself. So I think this is an opportunity for us to look at cancer holistically. So we need to work in a very thoughtful way, where we look at diagnostic centers, we look at treatment regimens, we look at all the various treatment options that we have, and then make sense of it using technology. So I'll just end my comments there.
Thank you so much, Dr. Kiran Majumdar-Shaw, for your excellent work you are doing, and thank you so much for joining us. So we move ahead with our ongoing discussion, and I'm happy that Professor Dinesh Pendarkar sir has also joined. And Dr. Dinesh Pendarkar sir is pioneer in the cancer network development in various community level, and currently he is not in India. So Professor Dinesh Pendarkar sir, can you tell us about how you try to connect various community doctors and about the training of doctors?
Thank you very much, Dr. Lalit. Before I speak, I want a small, if Madam is still listening, I have a small question to her. Madam, the biggest, you have done a great job, see, and you understand the things really very well in digital technology and AI. The problem we are facing with digital technology and computerization today is there are too many softwares, too many companies selling it, but the cost of using this software is very, very high. So I have been trying to introduce this software in multiple states and districts, and due to finances, we are not able to do it. Despite we being the developers of digital technology, we are not actually able to put it to the use where it is required. So my humble request to Madam is, please suggest us some way how we can actually take this digital technology to the places where the cost would not be a barrier, because everybody is asking for a per person or a per entry cost of a software, which no government is willing to take and no private agency is willing to take. So definitely, if we really want to employ digital technology in the country, we have to get out of this somehow, and probably some corporations should come together with some corporate fund or a corporate backup with some software and try to digitalize the country, which is need of the day. Thank you very much. So that's my question to Madam. If she can help us, we will be really grateful.
Sir, I'll interrupt you. Probably she has another meeting, so she has just logged out, but definitely what your inputs are. So we want to listen from you about your efforts for training of doctors and nurses.
Okay, so thank you very much, Lalit. I will just introduce that. So we have got, fortunately, a great team of oncologists all across the country. We have got best available possible treatments everywhere in the country. But the problem, as the today's theme of the World Cancer Day is, it is problem of access to care. The care has to reach everybody. Unfortunately, what is happening is the poor person who is there in the periphery, he has got possibility of getting free treatment if he goes to some hospital. So the free treatment is available either through Ayushman Bharat or through donation or through free hospital. So the qualified care is available, but unfortunately the patient is unable to access this care. So what we have to do is try to create a niche or try to create a point of contact in the periphery who can explain these patients that these things are available, who can assist him in the emergency. And at the same time, so when a patient knows that he has cancer, and by the time he goes to a cancer hospital, there is a time gap. So we want to create system where this healthcare worker is able to help the patient to manage the situation so that he completes the care which is actually available free somewhere else. So what we have tried to do is we have to try to develop a point of contact of cancer in a government hospital. We have done it in 200 districts of India. So a government medical officer is able to catch hold of this patient, handhold the patient, help him, in diagnostic assistance, in examination, in explanation, so that he can go to a cancer hospital and continue the care. For example, during COVID, a lot of major hospitals were closed, so patients were not able to reach there. So these hospitals, during these doctors that time did chemotherapy for them. When the hospital opened up, patient went back to the hospital. So what we have to do is try to create a system in the periphery which holds the patient. Now, if a digitalization comes in with this, for example, the hospitals in Rajasthan, if they get connected with one software, which software is also available to government hospitals and to private or oncologists, maybe the to and fro of the patient would become even much easier. So what we have done is created a system of cancer care linking a peripheral available doctor who is available in a government health system for free for the patient to connect to the whole cancer care system. Thank you. Lalit, please go ahead.
So much, sir, for your excellent work. And I believe, I don't know what time is in your clock at this time, but I'm so thankful to you for joining us from very, very far off place, sir. Thank you. We'll come back to you, sir. So now I'll move on to Professor Gopinath, sir, Dr. K.S. Gopinath, sir. You have also seen the whole era. So what do you feel that how can we train our paramedical staff, our nurses, our ASHA workers, ANMs about the cancer care? You need to unmute yourself, sir.
Yeah. Can you hear me now?
Yes, sir. Yes, sir. You are audible.
See, you have brought out a very important point. See, we are all looking at the formation of the National Medical Council of the country, increasing the number of seats for DM and MCH program, DNB program and other thing. And this will be more useful in a tertiary places. Numbers of seats has been increased. And tomorrow when they are coming out, they are finding it difficult to set whether are they able to give a good quality care, we do not know. At this juncture, what our IS4, whatever the program we are doing through, we should concentrate on some of the subjects like preventive and social department medicine in 500 medical colleges in the country. No department is involved in preventive oncology training of the patient. They go for ophthalmic program, they go for blindness program, where we have failed in Gogo. They are not getting involved in the preventive oncology program in any one of the medical colleges. My suggestion at this juncture is we are all involved in various kinds of program. We should create an MBBS doctor who can take up preventive community oncology, give him a certification, give him a diploma, give him a degree, so that he should be the leader. As the Pendarkar was mentioning it, that when they go to the peripheral part, today people are ready to go to tier 2, tier 3 cities to practice the specialty. We should create the platform, one. Second thing, this is regarding the medical colleges. Coming to the nurses, we don't expose them to what is called as preventive programs for the nurses. Everybody wants to nursing oncology, nursing cardiology, nursing neurology, and all those things. See, if we look at, these are the very important thing. We are already the people who are coming to join the medical schools and the nursing schools. We should concentrate, introduce the subject to them. At the end of the routine training program, we should develop the subspecialization, involve them in the preventive program, preventive oncology as an entity. Except few cancer hospital and other thing, preventive oncology program in our medical colleges, we are not able to introduce the preventive community oncology, where they are doing a so good work in their departments regarding the blindness, regarding the cataract program and all those things. My humble appeal is we should look at these things rather than increasing the number of seats for DM and MCH programs and DNBs. We should concentrate on nursing and community nurses, how we can utilize them, as well as the doctors with MBBS qualification. If they can get into preventive community oncology program, we will pick up this cancer at an early stage and then we will take it forward. This is what I feel, because we have done a lot of work in these areas. Even recently, we have developed one of the scans for early detection by Subhash Narayan and the group, so that all these things, to get it implemented, we need the infrastructure. So this is how I feel we should concentrate only on education, educational infrastructure, develop the people to execute our ideas so that we can pick up the early diagnosis, various kinds of preventive programs. That is how we should look at it. Investment on education is never a failure. We will be achieving so many things. This is my humble appeal that we should inform the National Medical Council, National Nursing Council, including the Ayush doctors who can get involved in the community oncology program. Along with that, they may combine the community cardiology, community neurology, so that the concept of community preventive program should be there in the minds of the every human being and every medical professional. Then only we will achieve what we are trying to do. Thank you very much.
Thank you. Thank you so much, Professor Gopinath, sir, for your excellent inputs. And in fact, I also realized that today was the first day in my medical university that we had a joint program on World Cancer Day, where Department of Oncology and Department of Preventive and Social Medicine, we both united together, and that was first for them, first for us also. And I think that is a beginning for us, and we continue doing the same model. In fact, more and more replica of these issues. So, Dr. J.D. Patel, sir, we had a dream of having cervical cancer vaccine. Like rightly mentioned, many countries are on eradication of cervical cancer. So, how about having a mass vaccination campaign for the cervical cancer vaccine? And what do you propose? How should we go ahead?
Sir, I think India being a large country with 130 crore people as a member of our country, I think mass vaccination is a good idea, but the issue would be the cost. So I think what Rajesh said is right because of the opportunity of making a lot of money. The Indian pharma company has increased their infrastructure of producing a lot of vaccine. Probably after a few months, they will be little free. So this is the greatest opportunity where all diseases which can be cured with vaccines should be treated well. So yes, ideally we should have vaccination because almost 24 to 25% of the women would survive, would suffer from cervical uterine cervical cancer. So yes, and this vaccination should be included in national vaccination program. And secondly, with my experience of doing huge amount of workshops and doing medical camps, I have realized that yes, if we spare time, we can sensitize people. And if you sensitize them and you make them aware that this is something which would probably would avoid getting you uterine cancer, cervical cancer, then yes, it can easily be implemented. So here the national, this non-communicable disease program can also have a lead that they can put it as a part of program of vaccination. And I don't think, after the experience of COVID vaccination, I think we are large country, but we are beautiful country, and people, even though we say that we are illiterate, believe me, we are better than literates. So 150 crore people, they have taken vaccine, Nobody can say that we are illiterate. Come on. We could be illiterate, but हम अनुभव से बहुत smart लोग हैं ना. So I think we can easily do it, sir.
Thank you. Thank you so much, sir, for your words of wisdom. And I think Gujaratis are always ahead of most of the inventions in head neck cancer and maybe at the country level. But I'm sure that the COVID has taught us a lot of things and we know our capabilities and
Yes,
probably
sir.
we will do it someday. So I think with this note, in the interest of time, I'll stop here. And at the outset, I thank Professor K.S. Gopinath, sir, Professor Pankaj Shah, Professor J.D. Patel, sir, Professor Dinesh Pendarkar ji, Dr. R.N. Meena, sir, and Vandana Gupta ji for their excellent inputs. And I thank Rajesh Sharma ji for giving us platform. And once again, I thank Dr. Kiran Majumdar Shaw for excellent inputs about the head, neck, and other cancer. With this, we end up this panel discussion. And once again, thank you so much and have a great day. Thank you. Over to you, Rajesh, please.
Sir, namaskar.
Sir, you need to unmute. Sir. Rajesh sir, you need to unmute yourself.
Okay, done. Thank you very much, Dr. Sharma, for this fantastic panel discussion. So many good things have come out for our learning. Now we have message from Cancer Control Officer, World Health Organization, Dr. Andre from USA. He has many things which he has achieved. The important thing I want to highlight, he is undergraduate in bioengineering. He received his MD from University of Pennsylvania, and then he is a trained surgeon at MD Anderson Cancer Center. He was involved in clinical research efforts focusing on cancer care in low resource setting, health system development, and strengthening cost-effective surgical devices, including serving as commissioner in Lancet Oncology Commission on global cancer surgery. Dr. Andre has joined WHO Department of Management of NCD, Disability, Violence, and Injury Prevention in August 2015 as technical officer, and his current projects include policy statement on cancer screening and a technical document on comprehensive oral cancer control. With this short introduction, I invite Dr. Andre.
Thank you, Mr. Rajesh. Just to begin, I would like to thank the organizers for bringing us together on this very important day, World Cancer Day. Thank you to UICC President, Dr. De Cruz, Dr. Misra, Dr. Babu, Dr. Prabhash. Thank you for all of you as participants, leaders in communities. This conclave is where the ideas of tomorrow will emerge. It is a privilege to be here and to work together to close the gap that exists in cancer and for vulnerable populations around the world. I'll begin now with some slides. What we want to focus on here is an understanding of what is required for us to reverse the trends that we see in cancer, and particularly the trends that we see in head and neck cancers, to save lives, to achieve global targets, and to provide universal health coverage. Let us first begin with an understanding. What are the driving factors behind the growing burden of cancer? How can we respond as a community? Second, to focus on universal health coverage. Why should we prioritize it, how to implement it, and what are we doing as a community to respond? And finally, just reflecting on what we've heard already in this conclave. What can WHO do to add to this narrative and to build relationships with you in India and across Southeast Asia? This is the most important starting point. The recognition that in high-income countries, 1 in 2 or 1 in 3 will develop cancer in their lifetime. But in countries like India, it is not that different, 1 in 5 or 1 in 6. That means that so many of us here meeting today, so many of our loved ones and our own families, ourselves included, will be affected by cancer. The prognosis for tomorrow is not better. The trends will get worse. The numbers will double. In fact, in India, looking at head and neck cancers, they'll increase 50 to 100% in the next 20 years. So why? Let us understand what is driving this burden. In general, there are 3 common categories that explain why cancer numbers are increasing. First, people are getting older. Second, their population continues to grow because of birth. And third, because risk factors continue to increase and the prevalence of those risk factors is increasing. In fact, the story of cancer is in some ways a public health success. The primary reason we see higher numbers in cancer is because people are living longer. And this, in fact, is a reality that will impact countries like India. But with head and neck cancers, we see another phenomenon. We see risk factors continue to persist. Age-standardized incidence rates are not decreasing if we look at them amongst men. So in fact, India, countries in Southeast Asia will suffer this burden in the foreseeable future because as people get older, the likelihood of head and neck cancers will increase and the risk factors we have not been able to successfully manage. So in this agenda, we think both about prevention and management. On the prevention front, the way we organize our approach is to group it into 4 general categories: behavioral, infectious, environmental, and other. In behavior, we know the primary risk factor, tobacco. Betel-quid are recognized for head and neck cancers, we know also to be the case. But infections are a very serious cause of the cancer burden overall, and in fact, for head and neck cancers as well. Environmental exposures, these will increase. Air pollution, occupational exposures, radiation, and of course, there are genetic factors that we've identified. The challenge with us in head and neck cancers is that there is no magic bullet here. Yes, we can deal with some of the primary risk factors, smokeless tobacco, but that won't be enough. We heard a bit already about the importance of human papillomavirus vaccination. We know, of course, that occupational exposures contribute to head and neck cancers, radiation, and other risk factors. So what is required, in fact, is a multi-sectoral response, recognizing that while there are some priority risk factors, all of them will need to be considered as we formulate a global response. But this global response won't be the same in all settings. When we look at which risk factors are most relevant in what countries, we can see that in a country like India, infections are a primary driver. This is not the case in countries in Europe, but in India, it's a almost three times higher level of infections that cause cancer. And this, of course, includes human papillomavirus, EBV, and other other infections relevant to head and neck cancers. So how do we generate a tailored response, tailored within the country, tailored by the government, and respects the needs to also address population awareness and individual level change that is needed? And on the control front, we know that prevention will not be the only way to reduce the head and neck cancer burden or the cancer burden more broadly. We start then to look at why are there differences in outcomes. In a country like India, if we look at some of the studies that have been published, in fact, there are hospitals, there are states, there are some communities where care really is reaching what we see in high-income countries, if not already looking to exceed it. But that's not the case for many people in Southeast Asia. And why? Well, how do we bridge that gap? This is the theme of World Cancer Day. This is an important principle to focus on as we look to make the agenda more active, more solution-oriented, and more realistic. So where do we start? Again, downstaging disease. You can see that early diagnosis programs are critical to the success of all cancer management, in particular head and neck cancers as well. How do we focus on early diagnosis and ensure that people can get to the hospitals and managed as quickly as possible? How about treatment complexity? Yes, it can help. We will hear a lot about the importance of advanced medical devices, new innovations in health products and cancer medicines, but we should not acknowledge going into it, given the current landscape of these treatment modalities, the impact will not be quite as high as downstaging. The same thing, of course, quality has an even more important impact than treatment complexity. And the last really is the foundation for success, offering care to everyone who needs it in Southeast Asia, whether they live in a rural community or urban, rich or poor, educated or unable to go to school. This is what will bridge the gap, focusing on universal health coverage. So what does that mean in practice? In practice, it means that first, let's understand why cancer fits in the UHC agenda. We know certain things are true. First, UHC is the most effective way to improve outcomes and promote equity. What I showed in the previous slide is not just about estimates. The reality has been seen in many countries. In a country like Thailand, Southeast Asia, when they shifted towards universal health coverage, they saw significant improvements in oral cancer. And the primary reason they saw that was not because of improvements in treatment. It was in fact because of downstaging. People said, cancer is a problem. Governments will help me. The hospitals will help me. Providers are there to respond to my needs, and they present it for care. So universal health coverage is about improving outcomes across the cancer continuum and promoting equity. And we also know this, that countries that have invested in universal health coverage are also the health systems that have been most resilient during this COVID pandemic and also during past economic threats. So how do we drive UHC through cancer control? Through 3 steps and ultimately through community engagement. First, to set priorities. Second, to invest strategically. Third, to focus on capacity building, particularly on cancer workforce. And fourth, community engagement. The starting point is difficult. We know that health budgets are very different between high-income countries and low and middle-income countries. You can see that if we estimate how much money is spent on cancer in a country like Switzerland, where I am now, it's between $100 to $400 per capita. In Southeast Asia, it's very different. It can be as low as 10 cents per capita. So how do you manage cancer when you have to do it on a budget of $5,000 or $10,000? And you compound that with what the government is willing to invest. We also see in many low and middle income countries, cancer is not included in public health insurance packages. As a result, we know that financial hardship happens. It happens very regularly in all of our communities. The statistics here are from Southeast Asia, but let there be no doubt that financial hardship is experienced by every person who is diagnosed with cancer in every country, just to varying degrees. So how do we protect against this financial hardship? Start by setting those priorities. If we look at priorities, we have to think about where is the money going to go, what interventions are needed, and what capacities do we need to build. As a starting point, we often talk about medicines and technologies. This is very relevant, but the primary driver is actually workforce. So we need to invest in people. When we look at the workforce capacities globally, we recognize that there are major gaps, and this will be the bottleneck to achieving universal health coverage. In a country like India, an oncologist may be responsible for a panel over 1,000 or 2,000 cancer patients. In a country like Switzerland, it can be as low as 1, 2, or 300. So how can we ask more of these workforce without investing in education and training? And this is not only for oncologists, but for primary care providers across the cancer continuum. And finally, community engagement. UHC takes time. It won't happen just because a government signs it into law. That is the starting point. But it will also happen because communities request it and communities implement it, partners across the board. That's why it's such a privilege to be here in a meeting like today where we meet as a community to discuss it. But things have changed. We live in a new reality. The pandemic has upended a lot of the progress that has been made in cancer and continues to threaten our health systems for the decades ahead. It happens in every dimension. We know that our people diagnosed with cancer are at higher risk of a COVID-related morbidity or mortality. We know that cancer services have been disrupted 50% or more in some settings. So what can we learn from this pandemic that will change tomorrow and make it more resilient? First, to think about, as we heard from Dr. Dinesh, new service models. How do we improve access to care relying on telemedicine, technology, artificial intelligence? How do we build those infrastructure, but also recognize that data needs to inform those investments? How do we build our capacities in workforce to respond to those new technologies? Second, to build momentum for universal health coverage. When we look in Europe, in some countries in East Asia, and ask what were the triggers for investments in universal health coverage, a lot of them came out during times of stress. The government said, as we have heard already, this time of stress changes our prioritization of health. So how can we build on the momentum, recognizing that health is a public priority and a policy priority? And then finally, how can we reorient the health agenda, the research agenda, so that innovation also serves the needs of cancer patients, regardless of where they live? At WHO, we are doing a lot of things and most welcome the involvement of the community. Learn from your outputs from the conclave and to meet again to understand how can we work together for this new chapter. There are many things, and for the sake of time, just to briefly highlight: new legislation to promote universal health coverage, training new capacities, bringing new innovation, and offering new cancer medicines to everyone who needs them, starting with children. We have major platforms that are being accelerated, initiatives like cervical cancer elimination that have relevance for head and neck. And finally, we have a planned global strategy on oral health that will also be released in the near future. So in conclusion, what do we do together? First, ask about universal health coverage. What are prioritized interventions? And India has a list. What services are covered and why? Does this ensure financial protection? What else is causing financial hardship? Second, as an action point, what are our communal priorities? We can't go to a government with a wish list of 100,000 interventions for cancer. What are the priorities and why? And also let's think about the indirect cost, the cost of transportation, lost employment, paid time leave. These are having a very real impact on our communities. Second, to think about people. To know that there could be 1,000 or more participants in this meeting is so most appreciated, because these are the people that will bring change. We need more health workforce capacities in cancer, or we won't achieve our goals. And finally, let's knock on doors. Let's find new opportunities to engage. Cancer is about a broader health agenda, but we can also align with other programs that have a similar message and a similar need. As we heard already, the relevance of the vaccine programs, EPI programs, NCDs more broadly. How can we advocate together? We can be both patient, that change will take time, but we also don't have time on our side. Many will die in the immediate future. Millions are dying each year from cancer, 10+ million people already. We can work together to change this. Thank you for the opportunity to speak. We welcome your feedback from this important conclave, the brain trust of today and the brain trust of tomorrow. Thank you.
Thank you very much, Dr. Andre, for your crisp message and setting the priorities for this important World Cancer Day. And also, the pandemic has taught us many things in last 2 years. One of the biggest important thing is how we can collaborate across countries for fighting a disease and for preventing a disease. The way vaccination has been rolled out globally. Learning from this, probably if the vaccination capacity after this COVID-19 can be utilized for prevention in HPV, you can take something in this program. I don't know how, but this is my submission. Thank you. Now, it is my proud privilege to welcome Dr. Jatin Shah sir. Dr. Jatin Shah is a leader who has created so many leaders across the globe in cancer care, an advocate for head and neck cancer training, education, and research, a teacher and a mentor to uncountable cancer experts all over the world. His success is, he has a very long introduction, but I thought his success is, he has created so many to take care of the world. So we welcome Dr. Jatin Shah sir, founder and CEO IFNOS, International Federation of Head and Neck Oncologic Societies, on World Cancer Day. Over to you, sir.
Thank you, Dr. Sharma. As I begin, let me share my screen. Okay, thank you very much. I also want to thank the program chairpersons, Dr. De Cruz, Sanjeev Mishra, Govind Babu, and Dr. Kumar Prabhash for inviting me to speak this evening. This is the 22nd World Cancer Day, and I want to compliment Anil De Cruz for organizing this conclave dedicated to head and neck cancer. The biggest problem of cancer in India following cervical cancer in women. But the focus of this program, and I've been listening to this program for the last hour and a half, is on awareness, prevention, and early diagnosis. And this is where I would like to focus my few comments. I have no conflicts of interest to declare. As we know, according to the last data from Globocan, we anticipate this year over 18 million new cancers around the world. And nearly half of them will have died from cancer, a significant impact on human life year after year. If you cumulatively look at it, it will wind up being hundreds of millions of people during this century. So the World Cancer Day was founded in 2000 by UICC with the focus on prevention and eventually abolition of cancer. How do we achieve that? And the focus would be on awareness about the risk of cancer, prevention, early diagnosis, early treatment, effective rehabilitation, palliative care, supportive care, and eventually improvement in the quality of life. And this can be achieved by improvement in patient care delivery on site, or by education of physicians and the public at large. And such efforts can be local, regional, national, and at global levels. So I will focus my remarks on global education in head and neck cancer and what the International Federation has done to promote that, promulgate that, and achieve the goal in a reasonable time. The International Federation was founded 33 years ago, and it has been a thriving, collaborative international organization which has created a major impact on head and neck cancer awareness, early diagnosis, and appropriate treatment for the patient, and has made also a major impact worldwide on head and neck cancer education, teaching and training for the physicians and surgeons involved in the care of patients with head and neck cancer. The federation is founded and is composed of 65 national head and neck societies covering 58 countries around the world and literally spanning the globe. So this is the reach of the International Federation in terms of promulgating awareness and education in head and neck cancer. It has numerous programs, and I will briefly touch upon these. It holds quadrennial world congresses, has the world tour programs, maintains an international collaborative database, observes World Head and Neck Cancer Day, and I will expand upon that, has a online fellowship. It offers observership grant awards and has programs of training in surgical techniques, and has innumerable online resources on its website for learning and educating yourself. The World Congresses have been held every 4 years since 1998 in Mumbai, Rio de Janeiro, Prague, Seoul, New York, Buenos Aires, and the next Congress will be next year in June in Rome, which will be the 7th World Congress of the Federation. The World Tour programs have been conducted initially every other year, and for the last few years, every year, and for the last 2 years, online because of COVID. But these programs have reached literally every part of the world. In the past, on-site World Tour programs were conducted in these locations around the world, giving a 2 to 3 day seminar on head and neck cancer management and diagnosis and treatment. The master courses on operative techniques are being conducted in areas of the world where expertise is not available. These are some of the surgeons who have volunteered their time and talent to go out to these areas to teach surgical techniques. The Global Online Fellowship is a tremendous success, reaching surgeons who do not have the opportunity to learn and train themselves to better improve the quality of care that they deliver to their patients. The purpose of this program is to improve the knowledge base and judgment of surgeons in all parts of the world, in their home environment, on their patients, within their available resources, in their language and their societal norms, to improve the quality of care of patients with head and neck cancer by remote, online learning and training in head and neck surgery and oncology. This has been a tremendously successful program. Every year we register from 60 to 80 candidates, and to date, over 340 candidates have graduated from this program from 48 countries. These are the locations from where the graduates of the golf program come from. And you can notice that this education program has trained surgeons who will have a ripple effect of training others, their juniors, and improve the quality of care of patients with head and neck cancer. July 27th, just like February 4th, is a day dedicated to awareness on head and neck cancer in particular. July 27th was the opening day of the 5th World Congress in New York, and that was the day that was declared as the World Head and Neck Cancer Day. And on this day, around the world, activities in cancer awareness, cancer screening, early diagnosis, courses on education, and public health forums, as well as media coverages, take place to increase awareness about head and neck cancer and its early diagnosis, prevention, and treatment. IFNOS has also taken initiatives in social media. IFNOS is present on Twitter, on YouTube, and other social media, as you see here, where activities of IFNOS conducted on a regular basis are exhibited and manifested. IFNOS also has its app, which is free to download on your phone, and that will keep you up to date with the activities of IFNOS. The benefits of the golf program has been successful in improving the knowledge base, as I said earlier, in the judgment of head and neck surgeons in all parts of the world. In summary, uplifting of the global quality of head and neck cancer care can be achieved at several levels: at individual, institutional, national, regional, global, through on-site and online educational and training programs. Global networking through collaboration of national societies facilitates development of global programs. The golf program in head and neck surgery and master courses on surgical techniques are successful prototypes, and periodic conclaves such as this offer a state-of-the-art review in cancer care to the world at large. Thank you.
Thank you very much, sir, for your kind message. And IFNOS has played a key role in transforming head and neck cancer care across the world. And it is a pleasure to have you on this World Cancer Day. Thank you very much, sir.
Thank you very much.
With this, I would like to invite a message from our program chair and President, Indian Society of Oncology, Dr. Sanjeev Mishra. Dr. Mishra, over to you.
The distinguished speakers and the delegates who are participating in this global webinar on head and neck cancers on the occasion of the World Cancer Day. On behalf of the Indian Society of Oncology, it's a matter of great privilege and honor for the society to be associated with this global conclave on head and neck cancers on this very special day. The Indian Society of Oncology is the largest body of which has the surgical oncologists, the medical, the radiation, the basic scientists, people involved from palliative care to pain relief, a part of this. We all know that head and neck cancers are one of the commonest cancers that we see in our country. And we've got an expert panel of speakers spread over the 2 days that we will be listening to it. And we have heard stalwarts like Professor Shah and Professor Anil de Cruz and Dr. Kiran Mazumdar-Shaw express their views on this. Head and neck cancer continues to be a big menace, even though with other cancers also increasing, and because tobacco consumption and tobacco use continues to be one of the major reasons for head and neck cancers. Unless and until we fight this menace together and have everybody on board, then only we'll be able to tackle this problem. In the past, a lot of efforts have been made, but yes, still more has to be done. And on the Indian Society of Oncology stands committed to this cause of fighting cancer, and including head and neck cancer. And we all, as one, would like to say that if we unite, there is no reason why we cannot overcome this dreaded disease and provide good care to those who develop, and also be able to prevent in the large society that at large in our country. Thank you again, and on behalf of the Indian Society of Oncology, we feel honored to be part of this, and I wish all the best for this 2 days conclave. Thank you.
Thank you very much, Professor Mishra, for your message. We are thankful to Indian Society of Oncology for supporting this and getting associated with the conclave. I would, before I invite the next speaker, Dr. Viraj Swarna, I would like to place on record and thank Dr. Clifford Hoodis, CEO ASCO, and Dr. Doug Pyle, Vice President ASCO, to get the ASCO associated with us and nominate Dr. Nishant Agrawal as ASCO speaker. We are grateful to Dr. Hoodis and Dr. Doug Pyle. I am also grateful to Dr. Rajendra Toprani sir, President, Indian Association of Surgical Oncology, and Dr. Chandramohan sir, Honorary Secretary, Indian Association of Surgical Oncology. Thank you, sir, for your kind support to this conclave. Now I invite Dr. Viraj Suvarna. Dr. Suvarna is Head Medical Affairs, Biocon Biologics. Over to you, Dr. Viraj.
Yeah, thank you, Rajesh. In fact, I was really impressed with the way you, right from the beginning, have kind of been a sutradhar for this very important meeting. Of course, it's a very important day, but I like the way you conducted it right from beginning till end. In fact, you've actually finished before time, whereas most meetings I attend, it's difficult to, finish the meeting on time. So thank you very much. I would also like to thank, the same people that you thanked, from ASCO as well as from WHO, so truly global. And even from India, we had, so many stalwarts. In fact, Dr. Anil de Cruz himself, I'm seeing him after such a long time. And I think he really set the context right in the beginning when he mentioned that head and neck cancer is actually the Indian cancer, in the sense, like, I think he mentioned something about 1/3 of cancers in India is because of head and neck. And obviously it's the oral bit and the fact that, people are still addicted to tobacco. And then he made another statement, which according to me, I think we should ensure that the lay public really should know this, that he said nearly half of cancers in general are preventable and a majority of cancers are curable. This is such a big thing because in general, we see it in movies also, but even in our own society, that, the moment somebody gets diagnosis of cancer, it's like, that's it, I'm going to die very soon, as though it's a death sentence, without realizing that it is curable in some cases, it is preventable, that's the most important. So all that we need to do is be aware, and maybe, like how we talk of lifestyle modification for hypertension, diabetes, and so many of the other chronic ailments, actually the same thing applies to cancer also. So if only we could do that, and then obviously early detection, because if that happens, then your chances of overcoming and, addressing it and actually being rid of it increases. So that is something that people should know. Don't lose hope. And if only everyone came together and actually helped in terms of the awareness, the education. I like the fact that Dr. Anil de Cruz also said that every month he wants a kind of training program to be organized. And he did mention that he would speak to Dr. Neera about it so that she can organize such a meeting. And every month, for 12 months. So that would also help, because as one of the doctors on the panel, they mentioned that it's more about the primary care practitioners and the others like nurses and others also who need to be really trained on how to detect cancer early, and then obviously refer to the right people as early as possible. So once more, I would like to thank all the eminent oncologists who are on the panel. Of course, we have one more day tomorrow, and I'm sure tomorrow also will be as exciting as today, because normally 3 hours meeting, whether everyone is there for the full 3 hours, and I found myself absolutely stuck to my chair and just listening to the presentations and looking at the slides, and then of course the discussion that happened, all extremely well done. I would like to thank, of course, my colleagues in Biocon Biologics, and of course your colleagues in the Managed Health Foundation for coming together and putting up this excellent meeting. And I'm sure it has helped others also, because you mentioned that this is also live on social media like LinkedIn, etc. So I'm sure many people have seen this, and it has given them hope that cancer I mean, one can survive, as in, rather than look at cancer as something which kills. The way I see it is there are so many other ways in which a person can die. And just because you have cancer doesn't mean that it's like a death sentence. You might outlive so many others who don't have cancer. So I don't think we should look at cancer the way people used to. And I'm sure with such efforts, and not just on World Cancer Day, but all the days. And in fact, Dr. Jatin Shah also told us that July 27 is a specific day for head and neck cancer, whereas today is like in general for world cancer. So maybe on July 27 also we should do something on specifically head and neck cancer. So that's all that I'd like to conclude with. Thank you very much, everyone, the audience, as I said, the speakers, the faculty, who are also panelists, moderators, and everyone involved with making this event such a successful one. Good night and stay safe and take care.
Thank you very much, Dr. Viraj, for summarizing the day and this vote of thanks. And you mentioned about the audience. So we had about 700 plus registrations from 38 countries, from 140 cities in India, which represents approximately 150 different hospitals, institutes, etc. And as we are talking on our portal, still we have 225 people logged in for the meeting. And so all of them, and apart from this, we have audience on our social media, that is Facebook, LinkedIn, YouTube, and all. On our YouTube itself, we have 3,000 subscriptions. So that count will be additional. I'll give you tomorrow. And now I invite all delegates for tomorrow's meeting as well, where we have program chairs, Professor Govind Gupta, Govind Babu sir, and Dr. Kumar Prabhash. The meeting will begin sharp on time at 5:30 tomorrow evening until 8:30. So please block your calendar and log again. Thank you so much. Nero,